Hi, it's Beth from Manx Radio Newsroom. Once again this week, the issue of assisted dying on the Isle of Man has been in the spotlight. Certainly been covered by the BBC as well, as the House of Keys members continued their deliberation of clauses. If you missed any of it, you can hear the full debate here. Set aside a few hours, eh?
I hand over to Dr Allenson, who will move that Clause 6 stand part of the bill. Dr Allenson.
Thank you, Mr Speaker. Assisted dying is a serious and extremely important issue, and I appreciate the dedication members have shown throughout the process of bringing this bill to the House and the contribution from members of our community with all points of view. I'd like to thank all honourable members for their patience and deliberations at last week's sitting when we commenced the debate on the individual clauses. Clause 6 makes provisions about the declaration a terminally ill person must make to evidence their clear and settled intention to end their life. The declaration must be witnessed and also countersigned by 2 registered medical practitioners, who must both be satisfied that the person making it has been fully informed of the palliative, hospice and other care which is available to them, but that the person nevertheless has a clear and settled intention to end their own life, which has been reached voluntarily, on an informed basis and without coercion or duress. Subsection 7 includes the safeguard that where either the attending doctor or the independent doctor has doubts as to the capacity of the person who has made the decision to end their own life, they can ask a registered psychiatrist to examine the person and their medical records and give their opinion regarding capacity. I'm grateful to Mr Hooper, Mr Thomas and Mrs Paul Wilson for their proposed amendments, which I feel clarify and strengthen the requirements, safeguards and qualifications necessary. However, I am concerned that Mr Thomas's amendment numbered 21 on the order paper, which omits subsection 9, would weaken the remit and responsibility of the 2 assessing doctors and makes the whole process reliant on the views of just one psychiatrist, who could then seem to override their professional views. With that, Mr Speaker, I beg to move that Clause 6 stand part of the bill.
Thank you. Mrs Barber.
Thank you, Mr Speaker. I beg to second and reserve my remarks.
Well, Mrs Paul Wilson to move amendment number 17, please.
Thank you, Mr Speaker. My proposed amendment is to add into the list of those who are not able to act as a witness to a person's declaration someone who knows they will gain financially in the event of that person's death. The rationale for including this is to support the principle that the choice to request an assisted death should be the clear and settled voluntary wish of the terminally ill person, and those who witness the declaration of the terminally ill person should not have a personal connection or derive potential benefit from the terminally ill person's choice. Honourable members heard from our witnesses last week. I recall it was Dr Davis in particular, who indicated that there seems to be little evidence in practice of coercion by family members or those who may gain from the death of a loved one. On the contrary, the evidence we heard was that family members tend to be very reluctant to support a terminally ill person's request for an assisted death. However, the amendment, I believe, is in line with the approach that the terminally ill person should be making their own informed choice without any interests of another person apparently or actually influencing that choice. The amendment covers those who know that they will gain financially in the event of the person's death. This is to recognise that there may be situations where an individual does not know, for example, that they have been named as a beneficiary in a will, and so they would act in good faith in that circumstance as a witness to the declaration. Mr Speaker, I beg to move the amendment standing in my name.
Mrs Kane.
Thank you, Mr Speaker. I beg to second.
Call Mr Hooper to move his amendments.
Thank you very much, Mr Speaker. There are 3 very minor amendments, I think, to this clause coming from me. 2 of them are technical in nature, and one of them, I think, is actually quite important. So Amendment 18 is a small technical amendment to ensure that 2 members of staff who both happen to work for Manx Care are not treated under the law as being in the same practice and therefore unable to jointly sign a declaration. That makes sense. Manx Care operates island-wide. It's very easy to have doctors that are completely independent of each other, but also both happen to work for Manx Care as an organisation. Amendment number 23 is a technical amendment which gives Tynwald the power to amend the schedule by way of Tynwald approval. This is relatively straightforward. If you're going to prescribe a form in primary law, it makes sense to have the ability to make minor alterations to that form subject to Tynwald approval, and again that Tynwald approval there is key. The schedule that the amendment refers to is purely the form of the declaration, nothing more, nothing less. The third amendment, amendment number 22, is slightly more important in terms of it's a policy change, in that the bill as present gives the department discretionary power to prescribe qualifications that medical professionals must hold in order to undertake participation in the assisted dying service. This amendment would actually make the requirement to prescribe these qualifications mandatory on the department, that the department must prescribe these qualifications. It is intended as a safeguard to ensure that there is some clarity, I suppose, on what qualifications we would expect, and to actually push the Department of Health and Social Care in this case to mandating and prescribing that in statute. Mr. Speaker, I beg to move the amendments listed in my name.
Dr. Hayward.
Thank you, Mr. Speaker. I beg to second.
Call on Mr. Thomas.
Thank you very much, Mr. Speaker. I'd like to thank the mover, the Department of Health and Social Care, and honourable members for agreeing my amendments last week. Government will now have to draft, consult on and then move in Tynwald regulations about residents, and Clause 4 now states that the assisted death request needs to be a personal decision reached voluntarily without coercion or duress, and having been informed about the person's diagnosis and prognosis and the treatments available, including pain control and palliative care. I would now like to move the 3 Clause 6 amendments standing in my name today, which are similarly practical. And I also welcome the indication of support from the mover already for the first 2 at least, and we'll come to discuss the third one. This is my only chance to comment on the other amendments, and it seems to me that Mr Hooper's and Mr Paul Wilson's amendments are eminently sensible, and I will be supporting them. I do agree that the change from may to must by Mr Hooper is an important statement of the Department of Health and Social Care's engagement in all of this, because that's absolutely fundamental. If we're going to do this, we have to do it with government support and do it right. Amendment 19, the duty to seek psychiatrist's opinion on page 8, line 22, is to substitute may for must in respect of seeking an opinion from a registered psychiatrist if either the attending or the independent doctor have doubts as to the capacity of the person making a request. I hope everyone agrees the importance of this psychiatrist's opinion and will support this amendment. Amendment 20, the psychiatrist to consider non-medical information on page 8 at line 26, is to insert after medical and other relevant. So the psychiatrist, before giving an opinion under subsection 7, must examine the person who has made the decision to end their own life and the person's medical and other relevant records. I imagine this would include the multidisciplinary team records Miss Edge mentioned last week, and that the visiting medics who gave us evidence last week assumed would be available. But of course I'm not qualified to imagine more about what these records might be, but other relevant records should surely be available, and I'm delighted that Dr Allinson agrees and that we should have other records there as this legislation becomes closer to law that's in place. In terms of Amendment 21, the purpose of the psychiatrist's opinion on page 8 and lines 27 to 30, that is to omit the subsection 9, which means that the psychiatrist's opinion is not only given only to assist the attending doctor or the independent doctor, as the case may be, in determining the capacity of the person to make that decision to end their own life, but is important in its own right. That was my point. Surely the psychiatrist's opinion is important and cannot be ignored. Dr Allinson has made the same point as he made in the Broad Street as we were considering my amendment, and it's a really good point. We do need more detail about how exactly this will work. And that is the point I've been trying to make throughout. We need to actually understand whether or not it is the case that now the psychiatrist's opinion, the way this is drafted, trumps that of the 2 doctors. That wasn't my intention. My intention was to make sure that this decision is taken properly, and it would seem to me that whatever the vote today on this amendment is something that the Legislative Council would have to look at, because we need the right process to make sure all of the opinions and all of the considerations are there, backed up by all the records, and are all taken very, very seriously. So I beg to move the 3 amendments standing in my name. Of course, like for everybody else, there would also have to be renumbering of the subsections in Clause 6 with corresponding adjustment of cross-references, which is also covered in my amendments.
Ms Edge.
Thank you, Mr Speaker. I'm happy to second and obviously support all of the amendments in the Honourable Douglas Central's suggestions. with regards to the psychiatrist's opinion, I think that's a really valid point, that perhaps we haven't had full consultation and understanding of the involvement of doctors and the calibre of the doctor, and to support the individual in that decision. So, and I completely accept what Dr. Allinson has said with regards to that, but Mr. Thomas has made it very clear this needs further work, and I think consideration to supporting his amendment should be at the forefront of people's thinking today, because this is not a straightforward process, and psychiatrist's opinion is important, but it shouldn't be about who trumps. It should be we know the right processes are in place for the people of the Isle of Man.
Now, I want Mr. Thomas to move a procedural motion.
Thank you very much, Mr. Speaker. I, for one, found the procedure of Committee of the Whole House very, very valuable last week, and I would like to move under Standing Order 4.4a that the House do resolve into a Committee of the Whole House to hear evidence from Baroness Finlay and Dr David Randall for a period I expect to be no longer than 1 hour on Clause 6 and on the new clauses. I would like to have Baroness Finlay answer questions, including on the case that assisted dying is only with a licence and without recourse to public monies in particular. Baroness Finlay is an expert on palliative care, I believe, assisted dying in its legislation. She is a consultant at the Belinda Cancer Centre in Cardiff, Professor of Palliative Medicine at the Cardiff University School of Medicine, a crossbench member of the House of Lords and past member of the Royal Society of Medicine and Association for Palliative Medicine. She's worked on many bills, for example, on stopping smoking in private places, on changing the system of organ donation from opt-in to opt-out, the regulation of sunbeds, and reducing carbon monoxide poisoning. So I believe she will be able to help us in respect of our prospective legislation, and particularly the issue of parliamentary sovereignty, perhaps. I understand she also chairs the all-party parliamentary group on dying well, is Vice President of both Hospice UK and Marie Curie Cancer Centre, Head of Division International Chair of Bioethics, Cooperating Centre of the World Medical Association, and a member of the BMA's Ethics Committee. And she has chaired the National Mental Capacity Forum, England and Wales, for Ministry of Justice. I'd also like to invite Dr David Randall to answer questions from a healthcare professional perspective. Dr Randall is a consultant nephrologist at the Royal London Hospital, has a research post at the William Harvey Research Institute at Queen Mary, University of London, and edits Kumar and Clark's Clinical Medicine, a leading medical textbook. He has campaigned for many years against the legalisation of euthanasia, assisted suicide in the UK, and helped found Our Duty of Care campaign, which represents the opposition of healthcare workers to a change in the law. In summary, he is a practising clinician and an expert in assisted dying, I suggest. Honourable members, I'm very pleased that we have such such high calibre witnesses who have travelled to the island today, so I hope you will allow us to resolve into a committee to hear from them. I beg to move.
Edge.
Beg to second.
If no member wishes to speak, I will put the question that, under Standing Order 4.4a, the House resolves into a committee of the whole House to hear evidence from Baroness Finlay and Dr David Randall for a period of no longer than 1 hour on Clause 6 and the new clauses. Those in favour, please say aye. Aye. Against, no. The ayes have it. The ayes have it. Well, could I welcome back Baroness Finlay and Dr Randall. You're most welcome here to the House of Keys today. I'll give you both the opportunity to make a brief opening statement, and then we'll open proceedings out to questions.
Thank you, Mr Speaker. If I might commence.
You are, and you're more than welcome to remain seated if that
okay,
suits you, whatever works best for you.
Yes, thank you. Thank you, Mr Speaker. I'm delighted to be invited to be back here. As was said, I have looked after many thousands of dying patients over many, many years. I also held a visiting professorship in the Netherlands after they had changed their law, and I had the privilege of sitting in on consultations where euthanasia was being discussed, and also post-bereavement after euthanasia, and had many discussions there with people over it. If I could make some comments about the legislation before you. First of all, I would have to say that I think at the moment, as it's written, it's not workable. It does need to be amended. One of the biggest omissions that you have is actually how the assessments are done, because they're being done behind closed doors by two doctors without really knowing exactly what's going on. And there are questions that doctors can't ask. We can't ask about bank statements. We can't ask about people's wills, what's written in them. That's not appropriate for a doctor. But actually, coercion, we know, is missed very often. Hourglass data shows that 1 in 6 people over the age of 65 have experienced some form of abuse, often financial or emotional or psychological, not by doctors. Doctors do not detect coercion, and sadly, I think many of us clinically have seen families that we thought were loving families until after the person's died, and then discovered things are different. The other thing is that I do think you need to listen to your own medical society, where you have a 61% response rate, which is very high, and your own doctors are clearly against this, and they want it operated outside of Manx Health. That's clear, that was the majority of responses, which is in support of the new clause that you have inserted. And I would remind you that nearly 3/4, 74%, are against the bill. And as you heard during questions, which I was listening to carefully, if I heard it right, you have a problem recruiting healthcare staff. You have a shortage of healthcare staff. You don't have a surfeit of healthcare staff. And so it's really important that you listen to them. Just in terms of the psychiatrist, I'd have to say delirium is actually quite common in advanced illness and terminal illness. It may be related to the illness, it may be related to the drugs, but certainly delusions are quite common. And I can't see how you can ask a psychiatrist for an opinion and then discount that opinion. It is tantamount to saying, well, the psychiatrist doesn't matter. And I'm not sure that the psychiatrist is very happy with that. I know that there has been an open letter from psychiatrists to you to point out that you cannot differentiate between suicidality in these in patients that is reversible and those where actually you could term it rational. And I point out that whenever people do go to the point of suicide itself, they believe themselves to be completely rational. Afterwards, survivors will tell you that they realise that they were not rational later on, but not at the point of it. There are other comments that I'd like to make over the clause, but I think for now I'll hand over to my colleagues, if I may.
Dr. Allen.
Thank you very much for the honour of inviting me. It's my second trip to the island, and I'm delighted to be back. I spoke a few years ago when this issue was previously before the House. I work as a nephrologist in East London. That means I look after people's kidneys, and I look after people on dialysis or who've received kidney transplants. I'm particularly interested in the healthcare of minority groups and of people in situations of deprivation and vulnerability. And that informs a lot of what I think on this issue. I helped set up Our Duty of Care. That's a collection of several thousand healthcare providers across the UK and the Crown dependencies, particularly strong actually in the Isle of Man. We don't really focus on ethical issues around this. We're much more focused on the clinical safety implications and particularly how this will affect the culture of healthcare, how it will affect provision of healthcare services and vulnerable patient groups. I would put it to you that any change in law will create winners and losers. And I think it's actually rather unfortunate to say that this is all very straightforward and that no one will lose out. In my view, in my clinical experience and from looking at the experience in other countries, the people who lose out when assisted suicide or euthanasia is legalised include the poor, the elderly, those who are being exploited by others, those with mental health problems, disabled people, and people from minority groups. And I view it as my duty as a doctor to fight their cause, not just to look after their dialysis or their transplant immunosuppression, but to ensure that the legal structures we work within medicine protect those people and ensure that they are not exploited by others. In my comments, I'm going to focus primarily on Clause 6 to do with the declaration, because that really involves so much about how doctors and patients interact. I have major concerns about it, and I don't consider it to be a safe piece of legislation. My concern is that it puts assisted suicide and euthanasia right in the centre of healthcare. This is something that will be happening in GP surgeries, on acute admissions units, on elderly care wards. That's where these consultations are going to be happening. As Baroness Finlay has outlined, I don't think doctors are the right people to be doing this. We don't have the skills for detecting coercion. We're not always very good at establishing capacity. I have many examples to draw from that. It seems to me that the legislation here is actually very similar to the Canadian legislation from 2015, which didn't last long, was very rapidly amended, and which has actually unleashed a real dangerous system for vulnerable people in Canada, and I'm worried that the legislation as stands will do the same for vulnerable people on the island of Man. Thank you.
Thank you. Now we'll turn it to questions, and some feedback was received last week about brief questions and succinct answers will mean that more members get the opportunity to put their questions and maybe follow up on early questions. First on my list, then, Mr. Thomas.
Thank you, Mr. Speaker. And I appreciate both of the witnesses coming to our island. I think it's probably Baroness Finlay who might want to answer this first, given something that Dr. Randall just said. But the basic question is, I think you said that the bill was unworkable. I want to put that question now specifically in the context of Clause 6, proposed Clause 6. Is Clause 6 workable, or is it unworkable? And if it's unworkable, why?
I think Clause 6 is the beginnings of it being workable. The problem is that this is just about who's involved, but there's nothing at all about how that assessment process is monitored. There is nothing at all about what has to happen or how you will audit it. And sadly, I'm afraid we know from countries that have gone down this road that sometimes the second opinion is very cursory at the end of the day. It is not as thorough as it ought to be, and that the assessment forms end up being tick boxes. And I would just remind you of the dangers of tick boxes, which were part of the Liverpool Care Pathway protocols that were meant to improve end-of-life care. But when they were rolled out, actually what happened is the boxes got ticked, but the patient was not adequately assessed and looked at. And the other thing that I would point out is over-prognosis. You cannot predict prognosis. The Department of Work and Pensions in England and Wales changed the benefits system so that benefits could be applied for a year ahead, but they have allowed a 3-year leeway of error. And in the event that somebody survives those additional 3 years, it would only be a light touch assessment for benefits after that. You just cannot predict. We've all had patients who we thought were going to be dead within days or weeks and who are alive months or years later. I had that situation with my own mother. So the assessment process is something which needs to be addressed and is not being addressed here at all. But I'd like to hand over to Dr. Randall, if I may.
Yes, thank you. To pick up a few specific points, I think, from Clause 6, it strikes me that there's very, very scanty requirements placed on the attending doctor. As far as I can work out, the only restriction there is that they're medically qualified and not related to the patient. There's nothing said about seniority or suitable qualification for the attending doctor. Now, that is of great concern. I can remember making terrible mistakes when I was a house officer, and I was a house officer in the days of the Liverpool Care Pathway. I remember, of my own volition, placing a patient on the Liverpool Care Pathway, which I thought was the right thing to do, stopping all medications, stopping all oral feeding and fluids, and that patient lived for several more days. He clearly was not dying. And then over a week later, we reversed that decision. And I look back with shame and horror, really, at what I did there. I was doing it from the best of intentions, but I was very inexperienced. I was contacted by a doctor in New Zealand who said they've had issues with house officers doing this in New Zealand against the wishes of more senior doctors because they think this is the right thing for the doctors. For the patient. No one's doubting their sincerity, but currently you have no requirements on the attending doctor to be suitably qualified. I've concerns about how much here is left to secondary legislation. So all the qualifications of the independent doctor needs to be defined by secondary legislation, which takes that outside the directly democratic process assessed by Tynwald. I've concerns that this is less tight than the Mental Capacity Act. Now, the Mental Capacity Act stipulates very clearly the training of the people required to deprive liberty to someone with a mental illness. This is less tight there. I'm concerned that you have the risk that a specialist psychiatrist opinion can be overruled here. That seems to me quite irregular. From my experience of medicine, I would never say that a patient had capacity if a psychiatrist said they did not. But I think if we move away from those specific issues, what happens if the patient mentions to their GP they would like to access assisted care and assisted suicide, and the GP is not willing, and no other GPs in that practice are willing? You may well experience this with 74% of Manx doctors being against this. Who would then become the attending doctor? It would have to be a doctor who doesn't know the patient, who comes in, assesses the patient as best as they can and reads the notes. But you would be losing out on the experience of those GPs who treated the patient for many, many years, knows them very well, knows the family situation. So I have concern there. And then finally, sorry to speak so long, but finally, I would just draw your attention to quite a number of public inquiries in the UK about how the culture of medicine can shift. I have printed out here the summary of the Francis report into the abuses at the Mid-Staffs Hospital. I have the independent reports 2018 from the Gosport Memorial Hospital, where a team had taken upon itself to bump off elderly patients who were admitted for rehabilitation. I have the Shipman report. I have the More Care Less Pathway report into the Liverpool Care Pathway. In each of those reports, the same message comes, that you can get institutions where the culture shifts. Patients are not treated with dignity and respect. The value of individual patients is not respected, and that is the concern when you have it embedded within healthcare. And I would really, really strongly recommend, as Baroness Finlay has suggested, that this needs to be removed from GP surgeries and hospital wards.
Thank you. Mr. Glover. Guru, my Lord. Certainly an alarm bell has been rung from your opening remarks there, where you compared this legislation to being more akin to Canada, which is something I think the movers have avoided having that comparison to. So maybe you could just clarion that alarm bell a little bit more. And also, how do you handle it when people tell you that they want to end their line?
Thank you very much. Okay. So to deal with those two things, the Canadian law was moved with the best of intentions, and parliamentarians were reassured that there were lots and lots of safeguards, and it was all being done in a very careful and controlled way. The problem came that this was established as a healthcare intervention. This is something where doctors are doing the assessment and doctors are providing the treatment. What happened was, after 2 or 3 years, equalities cases were brought where people were basically saying, why is this person allowed this and I'm not? And if your justification is based on compassion, then why is that limited only to people with a 6 or a 12-month prognosis? Actually, if people are suffering terribly, why should that not be applicable across the board? And that was the reason why, through the courts, legislators in Canada were forced to change their legislation. And I think you run the risk of doing exactly the same thing here, because it's established within healthcare as something done by doctors. To do with your second question, and I'm sure Baroness Finlay will have lots of examples. I've been asked once by a patient to end their life, which is interesting, and if you want, I'll tell you later why that was. But to tell you about that one patient, it was a fit, relatively elderly man who'd come in, and we diagnosed an aggressive malignancy, and it was quite clear that there weren't going to be good treatment options. And I'd been there on the ward round, the others left. I was the senior registrar. He called me back in and he said, look, what's the point? Can you just bump me off? I smiled conspiratorially and explained that we couldn't do that. And I said, what's making you feel that way? And we had a discussion. For him, it was that he thought, if I'm going to die in a few weeks, why don't I just die now? Why can't I just take control? Is there any point? So we talked a bit about that. We talked about his fear of symptoms. We talked about where he'd like to be treated, and we explored what the next few weeks might actually look like. And then we had a much broader conversation about where he lived, about his family members. We both liked boats, and we talked about sailing. And actually, it only took 10 or 15 minutes, but by the end of that, we were in a completely different place. And he was viewing his next few weeks of life in a totally different way. And actually, we didn't start him on dialysis, which I would have done if he didn't have cancer, because that wasn't something that he wanted. We're not in the business of pushing back death as far as we possibly can. Actually, death was coming naturally, and he had a natural death in a very dignified way with really good symptom support, because we were able to plug him into hospice services. And actually, it reminded me of how important it is to care for the patient and not just respond to that request. And actually, if I'd have said to him, oh yes, we've got a procedure for that, here's a form, let me get an independent doctor to help you make the declaration, we would have lost that opportunity, and we would have treated that man suboptimally, in my view.
Baroness Finlay.
Thank you. I've had a lot of patients who've said to me, just give me something to end it, I can't go on. And the straightforward response is to ask them why they feel that. What is making today so terrible? What is it that they want to do that they feel that they're not going to do? I said to you I had that situation with my own mother. She was in a hospice, expected to die within probably 6 weeks, according to the medical director, a colleague of mine who I respected greatly. She was very angry with me because I was opposing euthanasia at the time. And we eventually took her home. She lived for 4 years and then made a BBC radio programme with Radio Wales about how fantastic it was, those 4 years in which she saw her 2 great-grandsons born, and how her quality of life was unbelievably different. Early on, relatively early on in my career, well over 20 years ago, I had a patient referred to me by a GP who said, the only reason I'm referring him is I can't give him a lethal injection. He is the most clear-cut case for euthanasia I have ever come across. His surgeon, his oncologist, his GP, and I all thought that he had a prognosis of 3 months at most. He came into the hospice. He was not easy to look after. He took a great deal of work. 11 years later, his wife died, leaving him as a single parent of 3 relatively small children, the youngest of whom by then was 11, because that youngest one had been a baby when I first saw him. I have to say, going to his daughter's wedding was a very moving experience, and I was in tears, as were a lot of other people. But he certainly fitted every criteria in every bit of legislation I've ever seen. You just cannot predict how long people will live. And the last one I'd like to illustrate to you was when I was in the Netherlands and I was sitting in on a consultation. My Dutch was enough that I could understand, but not that I could speak. I could only speak in English. And this woman said that she wanted euthanasia. And I turned to the GP and said, she's wheezy. Does she have an inhaler? The Dutch all speak brilliant English. And she said, I don't want an inhaler. My grandson has one and he hates it. So I asked her a bit about it, and the long and short of it was, suggested that if she had the same inhaler as her grandson and he taught her how to use it, it might save her grandson's life one day on the sports field if he became very wheezy. Her reply was, oh, so I can still be of some use. Well, I'll have an inhaler. We'll talk about euthanasia another time. It was a tiny thing, but it gave her purpose in life. Repeatedly with patients, I've found that none of them have wanted to pursue either going to Dignitas or having lethal drugs, but they have very often had aspects of loneliness, unfulfilled issues in their lives, things that they thought that they could never achieve, and they need support and they need help to achieve them. And the other thing which sadly I have seen is where people have thought that pain and suffering was intractable, and actually it was because people had got something wrong with the diagnosis. And so that was another situation. So-called intractable pain, terrible pain, labelled as psychological, social, spiritual pain, and so on. Actually, I said, come on, we need a blank sheet of paper, start again, take a history again, and reinvestigate again. When we repeated the MRI, we saw the tiny metastasis, deposit of cancer, pressing on a nerve root that had been missed up until then. The treatment wasn't lethal drugs. The management was to get single-shot radiotherapy to shrink that, and his pain control was established.
Thank you. Next, Mr. Collister.
Thank you, Mr. Speaker. Thank you for all your evidence this morning. Just looking at clause 6, originally I proposed that the Isle of Man Court should play a role in this declaration, signing them off, checking them, everything else. But the information back from the courts was at the heart of this particular clause is a personal choice, a very personal choice. So my question to you this morning is, how can we strengthen or safeguard clause 6 around the declaration to improve it, especially on behalf of the individual making the declaration and on behalf of the medical professional? Or are you saying today that doesn't matter what we change or how we change clause 6, it will not be enough? I would like to because this one here, the declaration, is one that I'm feeling very, very passionate about. The courts on the Isle of Man are very clear, they just cannot be used. But is there anything in your minds to say what we should do to strengthen this clause to make sure that declaration is fair to the individual but also fair to the medical professionals? Thank you.
Okay. I would say that your own doctors are saying they don't want to be involved in doing this. So you need to find a way of doing those assessments separately. I also think that you need to record the assessments. I don't know whether the police here use body cameras routinely. They do, certainly in England and in Wales. Many emergency departments now use them for resuscitation techniques so they can audit them afterwards. There isn't a problem with confidentiality at all, but they're used internally. I think that you must record the assessments separately, and you must monitor those afterwards and review them to see whether they have been thorough or whether they have been treated like a tick box exercise and just be short. So that declaration by somebody is really only as good as the process of the assessment. Consent in medicine is about a process of discussion and understanding. The signature on the form is just about meaningless. It could be forged, it could be written under duress. Many patients sign consent forms for surgery and other things without really realising what they've signed. And they certainly don't read through the form properly. That's the reality. And I don't know how many people you have with literacy problems here, but certainly I'm afraid we quite often come across people who say, oh, I've forgotten my glasses, which is a good euphemism for I can't read.
Thank you. To pick up on the question of coercion, I don't know if anyone has watched The Sixth Commandment. It won a BAFTA this week, I think, and it's available on iPlayer, 4-part series. But it explores the really tragic case of Peter Farquhar, who was coerced and was eventually murdered by someone who pretended to be his friend, and that evaded scrutiny of all authorities. And it's a real-life case, and I, do watch it. Speaking about coercion, how difficult it is to establish coercion as a doctor. When I was a newly qualified consultant a couple of years ago, I was looking after a lady on the ward, and it was quite clear to me that she was dying. She had a number of different medical problems, and there wasn't an easy way through that. She was in a lot of distress and a lot of pain, and I was really strongly urging her have some pain relief, and that we could get the palliative care team involved. Her 2 sons were stood by the bedside who said, no, we're not doing that. We're not having palliative care. They were very afraid that I was trying to kill their mother, and that's the irony. I've campaigned all of my career against that, but that's what they believed that I was trying to do by using palliative care. When the patient was alone, she would say to me, yes, I do want pain relief. As soon as the sons were there, she would look at them and say, oh no, I don't. And a week later, she died in considerable pain, still attached to a dialysis machine, with a swirl of conflict in the room, with totally unrelieved suffering. And I feel terrible about that, because I felt I wasn't strong enough as a doctor to challenge these sons who were blocking their mum from having treatment. But each time I looked at her, she deferred to them and wanted to go with what her sons thought was best. And those sons were doing what they thought was right. I think they were very misguided. But that shows how I was aware of that coercive influence, but I wasn't able to challenge it. And it shows you really some of the deep complexities here. And the final thing to say is, if you get this wrong once, someone's been unlawfully killed. I'm sure we fail to detect coercion. I'm sure we get things wrong in capacity. Well, there's evidence that we do frequently in medicine. And at the moment, that means patients get the wrong care. If we get things wrong here just once, someone's been killed unlawfully. It was said in the Westminster Hall debate a few weeks ago by someone, oh, we're not a nation of granny killers. That's absolutely true. You only need one and someone's been killed unlawfully. And so, returning to your question of whether you can make this safe, I think you can make it safer by moving the assessment from the treating doctor to someone who's more independent and can ask questions, as Ernest Finney established about finance and so on.
If you were on the back end of the list, Mr. Colston.
Okay, that's fine, Mr. Finney. Okay.
I think you can make it safer. I am not convinced in my conscience that you can make it safe. 100% safe.
Next on my list, Dr. Allenson.
Thank you very much, Mr. Speaker. A question for Mr. Randall. I mean, first of all, this is not similar to the Canadian legislation. It's modelled very much on Lord Falconer's bill from the UK. Dr. Randall, you are a leading member of the Christian Medical Fellowship, and I noticed that...
I'm taking a visual cue from the gallery. Could you
I beg your pardon.
And direct your...
I beg your pardon.
Absolutely can't hear you. Start again.
So I will start again. So I do apologise. So a question for Dr. Randall. You stated that this bill is very similar to the Canadian legislation. It's actually modelled on Lord Falconer's bill, which was progressed through the House of Lords many years ago, and based on that. And obviously Canadian legislation, the change in that was very different because they have a very different constitutional and Supreme Court model. Dr. Randall, you're a member of the Christian Medical Fellowship, and although you said that you're not focused on ethical issues of assisted dying, I understand that when you and 2 other doctors took the Royal College of Physicians to the High Court in 2019 about their adoption of a neutral stance on this, you were quoted as saying, if legislated, assisted dying would represent the single biggest change of ethics and practice in medicine for a generation. Perhaps you could elaborate on that statement, why you think the provision of assisted dying is such a change for the medical profession and for the society in general.
Yes, I'd be delighted. I'll try to respond to each of those points in turn. So first of all, is this legislation like the Canadian one? Well, it is like Lord Falconer's. I think it's also quite like the Canadian legislation because it's embedded in healthcare. And I would just put it to you, if a patient not eligible under this legislation was to take a case to the European Court of Human Rights and say, why am I being denied this healthcare intervention? You know, they may well come back to Kimwald and say, you need to sort this out, you need to ensure equal access. So I'm not a legal expert, that would be something perhaps you would need to establish, and it might well be worth getting a legal view on that. To move on, yes, I'm a Christian. As you will have noticed, I haven't used any Christian argumentation in anything I've said so far. This is about evidence, it's about safety, it's about my personal experience on the wards, it's about looking... I've got printed off here the data from Oregon, for instance, which shows an increasing amount of euthanasia in assisted suicide in Oregon being done in people who are not medically insured. So it seems that there's a progressive trend towards poor people who can't afford good health care ending up accessing assisted suicide. This is all evidence. It's in the public domain. And what I'm drawing on is my experience of looking at papers and evidence and my clinical experience to present that to you. You refer to the case regarding the Royal College of Physicians, where there were some real problems with what they did. Their ethics advisor resigned over that, and we got a very positive outcome from the court, and they subsequently amended their position on behalf of that. Unfortunately, I think they've been very influenced by campaigners who are seeking to force through a change in law. In terms of whether, I'll address that issue which you brought up, which is this a major change in medical ethics? And I would say it absolutely is. One of the most, I think, unhelpful things that is said in this is that this is all happening already. It is absolutely not. I have never, ever seen a patient deliberately killed. And I've worked for over 15 years in a whole variety of hospitals around East London and Essex. I have never, ever seen a patient killed. All have their life shortened. When we use opiate drugs at the moment, we use them to relieve pain. We start low. We build up slowly until we've got the pain controlled. We work in healthcare. Everything in my hospital is electronic. Anyone can access the notes. Anyone can see what doses are prescribed. There are pharmacists on every ward. This is not happening at the moment. And it is very important to separate what this is from palliative care. Palliative care is about allowing a natural death with adequate symptom control. Here, we are crossing a Rubicon. We have a law that prevents doctors killing patients, and we're talking about changing that. So the doctor will be acting either to administer or supply drugs that will kill a patient. That is totally different from what we do at the moment. And so, yes, this is an absolute shift in medical ethics and practice.
Thank you. Mr. Speaker, could I clarify, do you wish me to speak to the new clause proposed as well during this time or not? Because I'm just aware of the time and your time as parliamentarians.
It's up to you. You can, if you want, certainly within the remit that the House has set for you at this point. Or I appreciate you'll have an opportunity to come back to that later on when the new clause...
I mean, I think it deserves a great deal of discussion. That's why I just want to clarify that we don't miss it. If I may then defer comments on that and just comment on the choice issue that was raised. The problem, if you're making a choice of any sort, you need accurate information. It must be voluntary, free of coercion, and you must have the capacity to make that decision. The bigger the decision, the more mental capacity you need. You cannot make a bigger decision than to end your life. So you really do need to have full capacity to do it. In terms of information, sadly, many people have witnessed inadequate care. Many people have seen bad deaths. They are emblazoned on their memory. That doesn't mean that changing the law for doctors to provide lethal drugs to patients is the answer to it. You need to actually improve your care provision. Even the person in the Netherlands, the politician who introduced their legislation, later said, we got it the wrong way round. We should have improved palliative care first. And they still haven't established specialist palliative care there after well over 25 years. In terms of choice, I'd have to say my experience with many patients, they let go of life when they're ready to let go of life. Many people are frightened of what lies ahead. If you've got distressing symptoms, that's a potent drive to respiration. It stops you relaxing, it stops you sleeping. If you have good symptom control and you are at peace, people just let go of life. My own father he outlived 9 months longer than his prognosis against all odds with a glioblastoma. My mother and I went into the room and my mother said to him, you can let go now. He opened his eyes, looked at us and promptly died. And that's been my experience with quite a lot of patients. I've even had patients say, I'm going to say goodbye to you tonight, doctor, I won't be here in the morning. They actually have decided just to let go and their body closes down. Now, if you're going to make a choice, it has to be your free and fully informed choice. And I would urge you to do nothing to jeopardise your hospice care on this island and your care of terminally ill patients. It is of a very high standard, but I would also remind you that you only 29% fund it. And here what you're saying is you will 100% fund ending life unless you move to the new clause. But I can say more about the new clause afterwards.
Thank you. Kevin.
Yes, thank you. Obviously, there's three requirements for the attending doctor and the independent doctor to assess. The third one of those is coercion or duress. You've talked quite a lot about this morning. Can I just ask directly what training is available to the medical profession in relation to coercion and duress? In other words, what specific qualifications will be undertaken for a doctor to be able to identify those criteria? More importantly, a clear and settled intention to end their own life, but the capacity to make the decision to end their own life. What, in your opinion, given that the psychiatrist opinion is just there for consideration, a doctor who is being required to either attend or independently assess is going to take of an individual who has autism, slight autism, or has some form of mental illness, yet is clearly still has the capacity to make that decision, and what situation is that likely to put a doctor in when they're dealing with a patient?
Okay, just in terms of coercion, having been a Vice Dean of a medical school myself, we had nothing on the curriculum that was specifically about how to detect coercion. And I don't know of anywhere that has a specific module of how to detect coercion. Doctors are trained to believe what the patient tells them. If you're a lawyer, you're trained to observe what goes on, and sometimes with an eye of scepticism, and wonder whether this is correct or not. I think that's why abuse is so often missed until it's barn door. And we hear so many times of situations of abuse going on, and afterwards people say, why did nobody pick it up? So I'm afraid coercion, I don't think, is taught. I wouldn't say it's adequately taught at all. In terms of capacity, I chaired the Mental Capacity Act, the Mental Capacity Forum for 6 years, which was to try to improve the implementation of the Mental Capacity Act in England and Wales. And I'm afraid to say doctors very often were really bad at assessing capacity. They even, some quite often thought that a mini mental state assessment equaled a capacity assessment. It didn't. And I undertook a review of cases from the Netherlands where we found a worrying number of people with autism or learning difficulties who had had euthanasia. And the comment with one really resonated, which was, this person could not adapt to the situation around them. Now, as you will know only too well, any of you who've got someone with autism in the family or someone with learning difficulties, you have to adjust the situation around a person to meet their needs. It's like asking somebody who doesn't speak Chinese to converse in Chinese. They just can't do it. You have to adjust the situation to match them. And one of the difficulties for many of these people is that they become ostracised, they become bullied, they become picked on, and they have a very distorted view of the world. And it's very sad, but there are a lot of young people with autism who really are under worrying influences. And then we could talk about the internet and all that they can access there, which is also really worrying, which is why we've had the online safety bill in England and Wales.
And very briefly, I've been told I have to assess patients for coercion. I've never been told how to do that. You know, we're told when you're establishing consent, you need to make sure the patient's not being coerced, but I've never had any training on how to do that. And just to come back, to give a slightly sort of softer perspective, these assessments of capacity are incredibly difficult. They really, really are. I can't think of anything more difficult or more stressful part of my job than trying to work out whether a patient has capacity to refuse this treatment. Literally, I lie at home awake at night trying to think, am I doing right for this patient who's refusing an intervention? Should I strong-arm them into do it, say they don't have capacity and push them to have this intervention, which might prolong their life, or should I respect their autonomy and not do that? These are incredibly difficult decisions, and healthcare professionals will come to different views on that. It's a really difficult part of being a doctor.
Thank you. Mrs. Christian.
Thank you. Just on clause 6, could you tell us how a doctor gets access to all...
Sorry, Mrs. Christian, I appreciate you addressing the gallery, but those at this end of the room need to hear you as well.
Do you not hear me too? Okay, sorry. Could you tell us how a doctor gets access to all hospital, GP, laboratory and private medical records, and how can a doctor ensure that they have all the relevant clinical facts? That's just on clause 6, thank you.
I can tell you how it works in my hospital. The truth is there's enormous variation depending on where you work, particularly in how advanced your electronic patient records are. I have very easy access to hospital records, so I can see what other specialties are writing in my hospital. If I go via a slightly awkward mechanism, I can see most of what the GPs write if they're using a system called EMIS. If they're using a system called System 1, then I can't access any of their GP records without physically writing to the practice and asking them to print off a big wad of paper and send it back to me. I can't routinely access private records unless the patient discloses that or sends me a letter. Pathology systems, I can see pathology results done in several of the hospital laboratories in East London, but ones done in other laboratories I can't access. So, and that's us, and we've got a relatively advanced electronic patient record where I work.
Just to add to that, I work in Wales. We have quite a lot of patients who get treated in England for one reason or another. That transfer of information is really difficult, and we often are aware that it's incomplete.
Thank you. Mr. Smith.
Thank you, Mr. Speaker. Baroness Finlay, what took you into palliative care originally, and why have you dedicated so much of your life and worked for so many years within that discipline?
Thank you. Well, very simply, as a junior doctor, I was angry at seeing bad care, and I felt somebody ought to do something about it, and wasn't happy to sit back and see patients consigned to a side room and their symptoms ignored, and wanted to learn more about it. I went into general practice, and then with another GP and then a small group, I then went off to St Christopher's to try and learn something from Dame Cicely Saunders, went back to Wales and thought if I could improve things in Cardiff, particularly in the community, then we might be able to improve things into the hospital, then we might be able to improve things across Wales. And out of that, actually, I established worldwide distance learning, and we've educated probably about 3,000 leaders around the world in end-of-life care. And what has driven me to keep going over the years has been that I think that bad care is intolerable. And I worry greatly that we don't have 7-day services, because disease does not respect the clock or the calendar, and crises arise at nights, weekends and bank holidays, and it is a tragedy if people can't get the care that they need when they need it. But in order to do that, you've got to have really good healthcare professionals' contracts that allow you to move people around. You've got to have a high level of education. But we went from just me in Wales to having, I think now there are 32 consultants. So I would suggest it's doable, but it's not instant.
Thank you. Thank you. Ms. Lord Brennan.
Thank you. Could you tell us a little bit about the experiences of other places where they have had assisted dying in healthcare? And also, based on that, and also what you've previously referenced, is there an argument for separating out effectively the prognosis and the provision of assisted dying, if you've got any points to make on that?
Okay, two very different. I would say that what I found in the different countries, with the select committee of the House of Lords that I was on, we went to Oregon and we went into that in detail. We were actually quite shocked at the several things. One of them is that they don't even keep their records. They destroy them after a year, so there's no ability to go back and look at things. That we were shocked at the lack of data collected, but you have to remember they're collecting more data than other places. In Belgium, I discovered from somebody in the Ministry of Justice, actually, that the claim that only 50% of theirs are actually reported was correct, and they're not being reported because people couldn't be bothered filling out all the forms, but they weren't chasing them up, which I found really worrying. And a colleague of mine told me of an instance where he'd felt under pressure to suggest euthanasia to some patients to clear some hospital beds. In Canada, I think the thing I found the most worrying, and I was there fairly recently, was the way that it's just become normalised in healthcare. Just an expectation, but without careful audit and critical audit of what's going on. And I was disappointed to see some very, very good doctors who have decided to leave palliative care, and an extremely competent GP who I met who took early retirement because he felt under such pressure he didn't want to do it. And it's very sad that their hospice there has lost its funding because it wouldn't participate. One of their hospices has had to close. And my experience in the Netherlands was interesting because I was trying to set up palliative care education, and the burden of providing euthanasia was great on doctors' shoulders, and almost half of every programme, sometimes more than half, ended up being taken up with discussions about difficult, troubling decisions they'd had over euthanasia. Interestingly, there's just been a paper come out recently about doctors feeling pressurised by families to perform euthanasia, or pressurised by patients and feeling unable to turn them down. But in their legislation, if a doctor says no, then that's it. You know, you don't get it. Whereas what we found in Oregon was that there's doctor shopping. And so the latest Oregon data shows that although most doctors don't want to participate, one had written, I think it's 79 prescriptions. And you just think, well, this is quite distorted practice. And in Canada, I have been very worried at a couple of doctors who have done hundreds of them and are doing that full time. And I do worry about how that distorts the whole provision of care. And what is the psychology of somebody who wants to go full time into ending life? But those are my comments from observing what happens when you include it in healthcare. And forgive me, I've forgotten in that your second question.
Do you think that there's an argument for separating somehow prognosis and the provision of assisted dying?
Yeah, very important question, thank you, because prognosis is impossible. So actually what happens is that somebody with a condition that may go on for many, many years, if they say, I'm going to stop eating and drinking, they automatically become terminally ill because you can't survive without food and fluid. And therefore they automatically would clock in to the provision, the way the bill's written. So I think it's an illusion to believe that you can establish terminal illness as a bright line. And actually, very often people can say with hindsight, oh, I realise that person was probably terminally ill from their condition, but the clinicians looking after them hadn't realised. And so it's not easy to establish it at all. I know last week you heard about multidisciplinary teams. They established the diagnosis and the treatment plan. I was on the Kalman-Hein committee that got that started years ago because we were horrified at sole operator surgeons and sole operator oncologists. So you do have to consult everybody. But you don't go back to the MDT to determine whether somebody is terminally ill or not. That's gradually the light dawns that they're not responding to their treatment, they're not so well, things are going downhill, interventions have become futile. Some conditions, of course, there isn't a treatment, some of the neurological conditions. Again, you cannot, though, predict how long somebody is going to live. Motor neurone disease is a classic. Some people, the majority, live about 2 years or so, but some people live very, very many years. Professor of physics in Cambridge being an example. You just can't tell.
Do you mind if I just come in on that one? Just to come in with some evidence to back that up around the prognostication, there was a big paper published last year looking at London data. And in London, we've got one of, certainly the biggest in the UK, possibly the biggest in the world, coordinated electronic palliative care system. So they looked at data from about 100,000 patients, and clinicians had to put in the likely prognosis. And this is a system that joins up GPs with ambulances, with hospital specialists, so that everyone's getting the same care from each different agency they access. It's called Coordinate My Care. So they looked at about 100,000 patients entered into Coordinate My Care. When you put a patient onto that, you have to say whether the prognosis is days, weeks, months, a year, or more than a year. So they looked at each of those groups. They found that prognosis was not bad when it's days, and it was not bad when it was years. If you think someone's survived for a long time, generally fairly accurate. But weeks and months were really not accurate. And so of patients given a prognosis of weeks or months, more than only 30% of them hit that, 32% hit that accurate prognosis. Lots more survive much longer. And that mirrors experience I've got in my own department. We've looked at the accuracy of our prognosis, not very good, and significant numbers of patients we look at and think, gosh, I don't think you're going to survive very well, do much better. I was actually contacted by a doctor today who told me about someone who 2 years ago she'd said, I don't think you're going to see Christmas. And she's had 2 Christmases and still alive. So things like that. I think accurate prognosis is a fool's game in medicine, actually. Sometimes you get it right. Often you don't.
Okay. Number 9 on my list, Mr. Hooper.
Thanks very much. I mean, you touched on a number of points in your evidence so far. You talked around the human rights implications and a potential challenge around expanding the law. We had some evidence last week from Mr. Foster, a barrister in human rights, who I think articulated quite well that the European Court of Human Rights position is that there is no positive obligation to provide, so it's an Article 2 issue. I think he was quite explicit about that, so hopefully that provides you with the legal reassurance that you were seeking. We've had that reassurance, I think, from the witnesses last week. You also mentioned in your evidence that the secondary process doesn't have any democratic oversight. I'm not quite sure what it's like in Westminster, but here our secondary regulations all go through Tynwald Court. They are all approved or otherwise, especially in the case of this bill, and there is also the process to refer that secondary legislation back through the branches here and LegCo. So our process is, I would suggest, far more robust than what you might see in Westminster. You mentioned as well in the bill there's no detail around capacity assessments. We have recently passed a Capacity Act which is modelled on the MCA in the UK, which does set out in quite some considerable detail how these things are to be progressed, so I wouldn't necessarily expect to see that detail replicated in this Act. There is a cross-reference, I believe, somewhere which identifies the capacity question. But the question I've got really pertains to some of the stuff you were saying around coercion and that doctors can't identify coercion and it's difficult to, if not impossible. I'm wondering if you've got any actual evidence, not anecdotes, but actual evidence that suggests that. If there's any evidence of prosecutions, regulatory action, disciplinary action in any jurisdictions that have rolled out assisted dying. And also I'd like to understand if there's been any prosecutions, disciplinary or regulatory action in any jurisdictions that have rolled out abortion as a legal right, because clearly in our Abortion Act there is also a requirement for doctors to identify coercion as part of somebody requesting an abortion on the Isle of Man. I assume that is replicated elsewhere. So is there any evidence of prosecutions, disciplinary, regulatory action being taken against medical professionals who have been performing either abortions or assisted dying in any jurisdictions where they've been rolled out that would support your argument that doctors are singularly incapable of doing this thing that actually we all know, and we heard evidence last week, doctors are capable of doing? It's not easy, but it is possible. So I'm just after the evidence, really, that you're relying on when you're making some of these statements.
So to take, I suppose there's, I don't know if that was 1 or 5 questions.
Just
Maybe
one.
If I take some of those things. I think the point is, if you're passing a bill on the basis of compassion, what do you say to your person who's not terminally ill, who's suffering terribly? How does that stand up to subsequent legal scrutiny? And how do you resist someone coming along saying, look, I am suffering absolutely terribly, my life is really, really awful, I've got a prognosis of 2 years, why can't I have this but this person can? And how does your law be robust enough to stand up to that very, very impassioned, well-meaning person? And that's the question. And that's what caught them in Canada, whichever the legal mechanism is. That's the concern. To come back to capacity, yes, we have the MCA in London. I'm well versed in it, but it's actually incredibly difficult to apply. We really struggle. Sometimes it's very straightforward. Sometimes you've got someone who clearly doesn't have capacity.
So
other times it's much to deal with this. You talked about other jurisdictions. I've got an email here from this is from a palliative care doctor in New Zealand. She writes this: particularly concerning are episodes where specialist doctors leading the care of patients have raised concerns that the patient requesting euthanasia does not have the mental capacity to do so. Several cases have been reported by senior doctors whereby the patient under their care has been extremely confused. In one case, eating their pillow and thinking it was food. In another case, thinking they were in a different country. However, when raising these concerns to the assisted dying service, they were told that this assisted dying practitioner knows how to assess the patient. The concerns were not taken forward. I and my colleagues feel too intimidated to speak out publicly about safety issues regarding euthanasia. And that was an email sent a couple of days ago from a palliative care doctor in New Zealand. You asked for evidence that we've missed coercion.
No, I didn't.
I mentioned already
evidence around prosecutions, disciplinary and regulatory.
So I've already provided one, which is the evidence of Peter Farquhar in this television documentary, and the person there has been convicted for murder, but the coercion had been missed for many, many years. And I think that's the real concern about missing coercion. You don't know when you've missed coercion. You cannot know that you've missed coercion. Very occasionally you can. Just to about missing these things, missing criminal actors, I think is a huge concern in this bill. And I want to read something from the summary of the Shipman report. I'm sure you're all familiar with Dr. Shipman. And the report says this: if Shipman was able to kill for almost 24 years before he was discovered, who can say with confidence that there are not other doctors still unknown who've not killed in the past? And Shipman's not the only one. We had Lucy Letby as well very recently in the UK. The concern is these people do exist. Sadly, there are actors out there, both working as medical professionals and acting as friends or relatives to patients who do not have good intentions. And the law has to be utterly robust in protecting vulnerable people from those individuals.
May I just add that in Canada there have been some cases that have been brought. Those of you who tonight watch the Liz Carr documentary that's on at 9 o'clock, the relatives of one of those is being interviewed, I think, the daughter of one of those people. And I'd just remind you, Shipman was referred to, no patients ran out of Shipman's surgery screaming, "He's trying to kill me." They actually let him inject them with drugs. That is really coercive. They were being misled and so on. You ask about abortion. I think that's a completely separate issue. In England and Wales, it's often provided by BPAS, the British Pregnancy Advisory Service, rather than that, so it's contracted out to a separate body rather than being provided in part of the NHS. I certainly know of individual cases of abortion where they were clearly coerced into abortion, but I'd have to say I've been heavily involved in abortion campaigning for it, performing abortions, signing the forms, and I think that's as much as I want to say about abortion, actually. Nobody should say I'm an anti-abortionist. I'm really not.
For all members, in line with the House's decision. That's 1 hour. We've had, just for information, because I'm sure that someone will be on their feet in a moment, 9 questions answered so far. There are a further 12 so far on my list. Now, I'm sure that someone will be on. Mrs. Christian.
Thank you, Mr. Speaker. I would just like to propose that we continue for the first part till at least 1 o'clock, or resume as we normally do after lunch for a further hour.
Which is it, Mrs. Christian? What is your motion?
Would you like to go to lunch now, Mr. Speaker?
No, we'll take lunch at the usual time. If it's an hour, then an hour will be accommodated. But I just need to know what your proposal is, so I can put it to the House, and the House is clear.
So I propose that we continue till 1 o'clock.
Okay.
More than happy to second that, Mr. Speaker.
1 o'clock. Ms. Edge.
Can I propose that we continue until all questions have been answered from all honourable members, and there may be more come up during this debate, so I think we should be considering, we've got guests over from England today, we should be asking all the questions and getting as many answers as possible.
Mr. Thomas?
Yeah, pleased to second that, but can I just ask for clarity from you, Mr. Speaker, because I think you mentioned a second opportunity for new Clause 6 to have another committee. Is that your intention to ask the House for that, or is that not your intention?
Well, as per the running order and per your request, Mr. Thomas, that there is opportunity to take evidence at this point, and also under the new clause later on, but not the new clause after new clause 6, admittedly. That's as it stands at the moment. But that's hope that clears that question up. So so we have 2 proposals. What I will do is I'll put first Ms. Edge's proposal, which will hear all the questions out. If that carries, that do you have a point of order, Mr.
No, I was just going to speak to Mr. Thomas's. To that second motion, if that's all right.
Yes, please.
Only briefly. It's only because I think Mr. Thomas's suggestion is quite helpful, actually, is if we do the next half an hour or so on Clause 6 specifically, and then there is a separate session to discuss new clause after Clause 6, which I think has also been referenced a few times. That might help focus the conversation a bit. So I think, for once, Mr. Thomas has a very sensible idea that I'm quite happy to support.
Right.
I don't think that was needed.
It's always needed.
Okay. Well, I think everyone's now clear on what the options are. There are 3 options. There are firstly that we continue with this until it effectively runs out of steam, which I take Ms. Edge's motion to be. The second one is that we go until 1 o'clock, and the third one is that we conclude this section of the evidence now. So I'll put them in that order. So if one fails...
I don't think that's what Minister Hooper proposed. I think he said on top of going to 1 o'clock, he then has another new clause. That's, I think, some people have to find.
Well, that would be a
hard.
separate motion when we get into the new clause.
Mr. Speaker, if we go to 1 o'clock, can we at that point decide that we want to carry on after lunch break?
You're always open to new procedural motions. You know how much I love them.
Exactly. We can assess.
Okay. So, Ms. Lord Brennan, you have a point of order.
A query, I'm sorry, I'm still not clear. So is it the situation that after the new clause is moved, that there is an expectation that there will be a proposal to go into committee again? Is that the situation?
I think that was the indication that Mr. Hooper and Mr. Thomas gave, but I am in the hands of the House at that point.
Yes,
But there seems to be a lot of nodding around the chamber, but I can do no more than sum that up.
Thank you.
Right. Mrs. Barber, point of order.
Sorry, not a point of order. I just want to talk to...
Okay.
Just very briefly. I suppose all I wanted to just to raise is my understanding around how the Committee of the Whole House works, because it does feel, both last week and this week, what we do have is some points where there is clearly some contention over the position of the expert witnesses, but also then other expert witnesses. So I just wanted to make it really clear, I suppose, that my interpretation is that everything that's said is the opinion of, in fact, just one person, and is not absolutely fact necessarily. And I suppose I feel that needs, because you can't have 2 people saying opposing facts that are the same, and I wouldn't want anyone to be under any misapprehension who's listening into this, that in fact everything is 100%.
Well, I'm absolutely confident that the witnesses are giving their honest belief and honest opinion to this House, and it is entirely possible that 2 different witnesses will have 2 entirely different approaches and opinions, and that's just the way of things. Okay. In which case I will put the House those motions as I set out. So the first one will be that we continue almost indefinitely until all questions are answered If that fails, then I put the question till 1 o'clock, and of course new motions could be put after that. And thirdly, if both of those have failed, that will conclude the evidence session. We'll resume the debate on Clause 6. Point of order, Ms Edge.
Mr Speaker, I'm just querying if I withdrew that and we just go with the other ones, because then we've got another option at 1 o'clock.
We do have another option at 1
So
o'clock.
I'm happy to withdraw.
In which case, I shall just put the question. 1 o'clock's rapidly approaching, honourable members. That we continue this evidence session until 1 o'clock. Those in favour, please say aye. Aye. Those against, no. The ayes have it. The ayes have it. Now, I just want to be clear, honourable members. What I will do at 1 o'clock is I will suspend the House for lunch, and on our return, I will take any further procedural motions. Is that clear?
Yes.
Okay. In which case, next on my list is Dr. Hayward.
Thank you. I'm going to keep my comments relevant to Clause 6 as such. So we've talked a little bit about palliative care and end-of-life care, and I know I speak from mine and probably other people's perspectives that in those palliative care situations there's a family conversation in a side room. Shall we make mum more comfortable? Shall we top up the drugs? You do realise that she will die quicker. From my perspective, that happens, and I know that happens, but that conversation is without the consent of the patient. And so under Clause 6, where you're actually going through and getting consent, it feels like a safer place to be for those medical professionals that are in that situation. So I wondered if you could perhaps comment about how it actually happens in reality, even though we just call it palliative care and don't really talk about the minutiae of it, but also in your experience, how often have you felt incapable of judging the capacity of your patient to the extent that you've needed to request a psychiatrist to come and make that assessment of the capacity for you? Our capacity legislation, as you know, is quite young, but actually there's quite a lot of training behind that. So I'm hoping that it's not the really inexperienced doctors who haven't really thought about it that will be doing this assessment. So perhaps you can talk about your experience of being able to judge capacity and what's actually happening in palliative care.
Okay. You talk about the discussion in a side room and the statement that the person will die quicker. There's no evidence that if you make people comfortable, you shorten their life. Those conversations are usually when people are very, very near the end of life and you're weighing up whether you're going to actually give them a little bit of sedation or that they're anxious or they have a degree of delirium and how you're going to handle it and what drugs you're going to use. What you're talking about with your bill is a discussion long before that happens very often. You've extended it to a year where you're having an open discussion with the person as to whether they will die or not. Actually, in palliative care, I would have to say that we try whenever we can to check out with the patient whether they actually want to have their drugs increased or not, because you must have the consent of the patient before you do something to them. To do something without consent is assault. And so those conversations that happen still need to be checked out. Even if you're changing the syringe driver, you've got it running as a subcutaneous infusion, you should be saying to the patient, we're going to change your syringe driver, we're going to give you a little bit more pain control in it. Are you happy with that? In terms of capacity, I can't give you the numbers of people, but I had the advantage of working with an extremely helpful liaison psychiatrist, and quite often I would ask him to see patients because I was worried about their mental state one way or another. And then I've had quite a lot of patients where they had delirium. We didn't need a psychiatrist to come in and say that they had delirium or a degree of delusion. But I'll always remember one patient who had consented to go into a clinical trial, but then actually hadn't. It was a very simple study. It was about mattresses on the bed against pressure sores. But then actually the next day it was evident he hadn't understood what he had consented to, and we took him out the study.
Thanks. I think it's a really two really good questions, actually, exploring what goes on here. The Association for Palliative Medicine have got a very good statement on the principle of double effect, which I think you're sort of alluding to, that you treat the pain accepting that you might slightly shorten life. I feel as an ethical principle that's acceptable. The priority is to get the patient out of pain. The practical experience is you don't really have to do that. That doesn't happen. That actually you go up incrementally on your pain relief until you've got the pain controlled, and it doesn't shorten life. And actually, there's evidence that if you provide good palliative care, people actually survive longer. But as a principle, I'd be happy with that. Though I genuinely don't think it happens. I don't think it's a practical consideration. I haven't been aware of that. To come to the second thing about capacity assessments. We make capacity assessments all the time, and generally they're very straightforward because generally there's agreement between doctors and patients about what's best. And as you'd be aware of the 4 principles of can they assimilate the information, retain it, use it to process, and then communicate that decision. And we will be doing that fairly regularly. I very occasionally get psychiatrists involved, and it's when there's conflict. And it's particularly when I'm suggesting something that I think will be really helpful to the patient, and they refuse that. And sometimes if I'm convinced in my own mind they've got capacity, then I say that's fine. You have the right. I did this just on Friday with someone who was refusing hospital admission, which I thought was very dangerous for him. I concluded he has capacity, and I didn't take that further. If I'd been concerned that he was confused, then I would have got a psychiatrist, which is a really important part to make sure that we're not doing things against patients, that we're not disadvantaging patients who are confused, who have an organic disorder of the brain that's affecting their ability to make decisions. In practical terms, it's very tricky, and often when you do get the psychiatrist, it's really not clear. And obviously capacity is decision specific. So you could have capacity to say, I don't want to have lunch, but not capacity to say, I don't want this life-saving surgery. So it's actually quite subtle and quite difficult. And I have been in situations where different clinical teams have written in the notes, this patient has capacity, this patient doesn't have capacity. And that becomes really, really difficult. And sometimes then you need to get ethicists or the legal services of the hospital involved.
Mr. Morehouse.
Thank you. Is it an accurate interpretation of what you said this morning to suggest that asking for an exit strategy is part of the natural end-of-life cycle, and that in terms of if a euthanasia pathway was available, then people would actually look at this as a normalised option? And in terms of slightly different question area, when a doctor in the UK turns off a ventilator with a patient with motor neurone disease, is that actually euthanasia?
Thank you. I think that's a really helpful clarifying question. Personally, the bulk of my job is looking after dialysis patients, and I'm a great enthusiast for stopping dialysis. Now, when you stop dialysis, patients die within 2 or 3 weeks. But where you've got someone who's clearly coming towards the end of their natural life, and I've got patients who have dementia or they've got a malignancy and it's clear they haven't got long to live, I have those conversations with them a lot, and I say, look, do you really want to keep coming up and down to hospital 3 times a week to have a 4-hour treatment session? Do you really want to be having blood tests and tubes put in your neck and this kind of stuff, which is all burdensome and difficult? And I would be encouraging my patients to think about limiting care. And actually, I think some of this drive towards assisted suicide is driven by a real fear of over-treatment. I would have that. If I knew I was going to die, I would not want to be up and down having lots of chemotherapy if it wasn't going to add very much to my life. And I think we need to be much better at withdrawing care. So the example you give of withdrawing a ventilator, that is entirely appropriate. That is good medical care. And it is a totally different thing from what's being discussed in this act, where you're acting to kill a patient, to take their life. That's the opposite. Yeah.
Thank you. A very important question that you've asked. First of all, I didn't say that wanting exit is a normal part of your illness. I've said that I have had patients who've said that. I've also had a lot of patients who've asked if there are any other treatments that they could have to prolong their lives. Complete range. Stopping a ventilator, important, and people don't understand. Without the ventilator, the person would have already died. They have been kept alive by often non-invasive ventilation that they've had at home. It may have been months, it may have been years. When they withdraw their consent for that treatment to be ongoing, they have decided they want to stop the ventilation, they refuse consent for it to continue, and they die of the disease of which they would have died a long time previously. In an intensive care unit, perhaps where you have people who you're treating, you will come to the point where you realise that you will not reach your therapeutic goal ever because their condition is such that they will not improve. That intervention becomes futile and you cease a futile intervention. That again is quite different to giving lethal drugs with the intention to stop life weeks or months or perhaps years earlier than life would have otherwise ended. So they're the complete opposite. In terms of the reason for not offering it, I think we would come on to that later, but I would just say that if a doctor offers something, there is an assumption that it is a therapy, that it is going to improve their situation. If you offer to a patient that that they could have assisted suicide or euthanasia, what you're saying subtly is actually, I think what lies ahead of you is so terrible, and I'm not going to spell it out, but this might be your best option. You are actually subtly, inadvertently coercing them down that road, rather than it being a blank free choice. If somebody says they want to die, then you must explore that and find out the cause of their distress. That is quite different to initiating an offer.
Ms. Edge.
Thank you, Mr. Speaker. Thanks, speakers, so far. I've heard an awful lot around governance, and I'm not really hearing any answers around governance and process. Clearly, you have concerns that actual process and signature and everything is not adequate in our bill. I'm concerned more from some of the contributions that we've heard today. The Isle of Man's very lacking in electronic joined-up systems. Our multidisciplinary team meetings, how often are they offered without people advising families that they can be offered? But more concerning is with regards to our vulnerable in society arriving in a hospital setting and current utilisation of do not resuscitate as an option as well. So if our bill goes through and it's 12 months, it's not actually an option. It seems to be slapped on people quite readily. What's your experience of do not resuscitate usage and also the governance structure? And obviously you've got experience in the Netherlands. What is their governance structure around assisted dying, how that process works, and linking with the medical profession? We already know our medical professionals on the island do not want to be involved in this, and I was really concerned to hear your words, holiday shopping, doctor shopping. We haven't got any doctors that we'd be able to shop for this, and I think that's significant to the Isle of Man, and everybody needs to hear those words from our doctors. There'll be very few willing to be part of this. How many are left? Could that involve coercion at that point?
Okay, thank you. In Wales, I was involved in the policy over do not attempt cardiopulmonary resuscitation, and my colleague developed Talk CPR. I won't go into details now, but you're very welcome to look at it on the web. It's won quite a lot of awards, and we will give patients a portable little video they can take home where they can discuss with their family whether, in the event of a cardiac arrest, they would want CPR or not. Nobody should have do not resuscitate slapped on them, because most of the things that you do are resuscitative. Giving antibiotics is resuscitative, giving fluids is resuscitative, giving insulin to somebody who is diabetic, or sugar if they're hypo, is resuscitative. So what we're talking about is, in the event of cardiac arrest, do you want somebody to bang on your chest, defibrillate you, and so on? And that is an advanced decision to refuse treatment. And advanced decisions to refuse treatment are in our Mental Capacity Act. So if I can just kind of dispense with that one straight away. David, I don't know if you want to add to that.
Two observations. On the issue of do not resuscitate decision, do not attempt CPR decisions, as they're called now. The thing that strikes me is how variable practice is. I completed my training, and in UK medical training you move between hospitals almost on a yearly basis. I've worked in my current department, we're very slow to use DNA CPR decisions. We would generally use them only in someone we think is actively dying on the wards, then we would begin that conversation, or in someone who's incredibly frail after significant discussion with them. I've worked in another hospital late on in my training where patients admitted to hospital couldn't leave A&E without a documented discussion about DNA CPR. They wouldn't allow them onto the ward before that had been discussed. So there, if you're the admitting doctor at 3 a.m. and you've got someone you've never met before who's got pneumonia, they look terrible. Most people look terrible at 3 in the morning, especially if they've got pneumonia. It is not possible to have that conversation. So I objected and I refused to do it when I was there. Come back, I just want to talk about the doctor shopping thing briefly, and I'll come back to you. On the sort of issue of who's going to do this, I think it's just worth reflecting that opposition to assisted suicide euthanasia is not spread equally across medicine. And I've got the results of the BMA poll from the UK, which was done 2 years ago. Quite a large survey. I think it was about 30,000 doctors were surveyed. Broadly, I'll summarise, but broadly, the people who were most pro-assisted suicide euthanasia were medical students, doctors who weren't currently in clinical practice, and doctors in non-patient-facing specialties, and outpatient specialties, HIV, retired doctors, radiology amongst them. I'll just read out the figures for the specialties that were most opposed. So this is to the question, do you support or oppose a change in the law to permit doctors to prescribe drugs for eligible patients to self-administer to end their own life? So that's assisted suicide. In terms of people who are most opposed, palliative medicine, 76%, geriatric medicine, renal medicine, that's my specialty, clinical oncology, gastroenterology, general practice. These are the most opposed specialties. Actually, when it came on to euthanasia, which is included in your bill, so doctors giving drugs, 84% of palliative doctors were opposed. Only, I think, 6 or 7% would be willing to participate. And again, it's the more enthusiastic specialties tended to be the ones who weren't actually treating frail and vulnerable people. So coming back to your question about vulnerability, all of those specialties who deal with elderly patients who are most at risk from abuse here, they're the specialties that are the most opposed: palliative, geriatrics, general practice, general medicine.
Thank you very much. Now, in line with the House's decision, I will suspend the House and we will resume our deliberations at 2:30, Honourable Members. Faster, Mike. Good afternoon, Honourable Members.
Order.
Now, before this, we had been taking evidence, and I said that when we resumed after the break, I would hear further procedural motions. Mrs. Christian.
Dr. Hayward. Go on. Just to firstly say that Mr. Hooper made a really good point to go into a committee of the new House for Clause 6A. I hope that we do agree to that later. But I would like to suggest that to the members, honourable members, that we continue to hear the rest of the questions for Clause 6. Thank you, Mr. Speaker.
Right, so Dr. Hayward.
Thank you, Mr. Speaker. I'd like to propose a different solution, if I might, that we hear from questions from those that haven't yet had an opportunity to ask the questions from these particular witnesses, and then we move on.
Okay. Ms. Edge?
Second, Ms. Christian, please.
Okay. And Dr. Allenson.
Thank you, Mr. Speaker. I'm very grateful for the witnesses giving their opinions. We have had an hour and a half doing that, and I would like to second Dr. Hayward. I think it's absolutely right that everyone gets a chance to ask a question of the witnesses, but I'm also keen that we go on to debate Clause 6 that's set out before us in a timely manner. I'm also aware that we have another witness that we haven't heard from yet regarding a further clause, and I think given the time of day it would be good to move on, especially considering the extensive amount of opinions we've had from the witnesses. Thank you.
Yeah. Mr. Morehouse, if you'd care to resume a seat, I wouldn't want to deprive you of your vote. In which...
Can we speak to a motion?
You can speak to the... Yes, you can speak to the motion that's been
just
seconded.
with regards to what Honourable Member for Ramsey's proposed, when we've set out into committee, we were only given one opportunity and we were told we could come back later. So I think it's a bit disingenuous now to try and take that opportunity away from members, and no members had the opportunity to go back and query anything that was said. So we might well have jotted things down that we wanted to clarify and make sure very clear for ourselves and for the public listening. So I think it's a bit disingenuous to suggest that when we were given that it was mentioned.
Well, as I say, I've been quite clear all the way through this that we're in the hands of the House, and the House can resolve one way or the other how long it wishes to hear evidence for. Mr. Glover.
Yes, I'm totally against what Mr. Dr. Allenson said. We are suppressing evidence in a way there, or attempting to. It's impolite as well to our witnesses who've given up their time to come here. People will have made other points that they want to just get clarification from the committee, and it smacks of being undemocratic.
Yeah.
I'm not sure about that.
Right. Okay, well, in which case I will put first that... now, can I just seek clarification from Mrs. Christian in terms of the nature of your motion? Is it that we hear the remainder of all questions, or is it that you wish to hear from the remaining 9 on my list?
The remainder of the questions, which I've understood, as you said, is 9 questions.
Well, so it's the remainder that are on my list now. So in other words, the list is closed. That's my understanding of your motion. Okay, so now everyone hopefully is clear on the 2 options that are, or the 3 options that are in front of you. I will put Mrs. Christian's motion first. If that fails, I will put Dr. Hayward's motion. And if that fails, then we continue the debate on Clause 6. Is everyone clear?
Yeah.
Okay. In which case, then, putting Mrs. Christian's motion that we hear the remainder of the 9 questions on my list. Those in favour, please say aye.
Aye.
Against, no.
No. Aye.
Division called. Uh, 14 for, 10 against. The ayes have it. The ayes have it. We will then proceed to hear the remaining 9 questioners on my list. Next on that list is Mr. Collister.
Well, thank you, Mr. Speaker. I would just like to go back to an earlier session where we talked about coercion, if possible, and the sign of the declaration. I know there was a lot of evidence being given on this particular point, but one thing you haven't put on Hansard or very clear with the public is that you do have a duty that if you believe coercion is happening, you should report that at the earliest opportunity. I am absolutely clear on that point, because you didn't make that very clear this morning. You almost gave the impression that that this could happen and you wouldn't do anything. Can we just get clarity that absolutely, if you were aware of any coercion, you would report it at the earliest opportunity?
Absolutely.
Thank you.
It's a safeguarding issue.
Agreed, but this morning you gave the sort of overview that this would happen, right, and you gave the impression that you wouldn't be able to do much about it, and that's not actually correct. Thank you.
Well, of course, that's an observation, but now, Mr. Glover.
Guru Maidal Order, what is your experience of hospice provision in countries that have taken on assisted dying?
Throughout the world, everyone's been trying to improve hospice provision and hospice care. So everywhere, it's generally increased in terms of quality of palliative care. But there's been one study of the European countries to see what has happened over time. And in those that have gone down this road, they haven't developed as fast. Their development has been slower. Quite significantly slower. And then if you look at New Zealand as well and Australia, they've dropped in their world rankings, all of them. The only place that hasn't dropped in its world rankings is Switzerland. And in Switzerland, it's not part of their healthcare system in the same way as it is in other places.
Mr. Cannon? No. Dr. Allinson? No. Mr. Thomas?
Thank you, Mr. Speaker. I want to unpick a little bit more some of the legal aspects and the relationships between courts and Parliament. So we've had some sort of comment and nodding heads and disagreeing in an agreeing way and an agreeing way about human rights law. I wanted to unpick a bit more about the Equality Act aspect of this, because we've got a well-established Equality Act in the Isle of Man. We have a tribunal. I just wondered how that might play out. And the second one is, especially when we get to these legal aspects, how can we assure the process in this assisted suicide, assisted dying regime? You talked this morning about body cameras. You talked about records being destroyed after a year in Oregon. What's absolutely important in terms of assuring the process, especially in that legalistic environment as well?
Okay, thank you. Can I take that from the point of view of a legal challenge, and the relationship with your legislature and the courts? I would expect that there would be a challenge under your Equality Act to this as being discriminatory, because you're trying to draw a line around terminal illness. So if I could give you an example, what happens to someone who's had a catastrophic motorbike accident in which they perhaps have very severe injuries, but actually none of that is now life-threatening. They have a long life expectancy, but they don't want to carry on and they would like to have access to lethal drugs. I would expect they could bring a challenge under your Equality Act for it being discriminatory. So I think what happened in Canada was slightly different, because their courts said to their parliament that they needed to look at their legislation again. But what doesn't change is the fact that there are then pressures to extend the law irrespective of what your parliamentary system is. And that's how I would expect a challenge to be brought. In terms of process being assured, I've said already, I think that monitoring the way that assessments are undertaken would be absolutely essential, and they should be fully recorded and open to analysis, and that can all be anonymised so it doesn't compromise the identity of the applicant.
The only thing I would wish to add on the issue of assurance and quality control is, and it's slightly off what the clauses we're discussing today, but just on the subject of 11.2, which talks about not recording assisted suicide as the cause of death. That would give me concern, in the sense that if a patient with a terminal illness was to be hit by a car, the injuries sustained by that will go on the death certificate. I think it is important that is recorded, how they actually died. And in this case, the mechanism of death does not relate to the malignancy. According to that death, I would be happy for that malignancy to be in part 2 of the death certificate. The way it's done in the UK, I'm not sure how similar it is here. But I don't think that assisted suicide should be omitted from the death certificate.
You have a proposal further in your legislation to have an oversight body, reporting body, but I would suggest that should be linked to your coronial system and should be under the jurisdiction of the coroner. so that you could undertake post-mortems to ascertain whether there was accuracy or not prior to death. And they don't have to be invasive post-mortems. They can be done.
Thank you. Mrs. Barber.
Thank you. I just wanted to go back a little bit around the capacity assessment and the coercion. You talked about the challenges there are with that. And I just wanted to give, I suppose, one example around the Association for Palliative Medicine. They have guidance about withdrawal of assisted ventilation at the request of a patient with motor neuron disease. And I believe that's endorsed by the Royal College of Physicians, Royal College of Nursing, General Practitioners and Hospice UK. And in that, the assessment does talk about the need to have a capacity assessment, that there is no coercion. So I just wondered how doctors comply with those guidelines relating to capacity assessment and recognition of coercion at present, and why you think that the same skill set wouldn't be able to be used with assisted dying legislation.
The answer is we do our best. You know, we try to do this. We often don't have good training, and actually, if we go back to the context of this, we're trained to ask different kinds of questions as doctors. Baroness Finley's already talked about how we're trained to believe patients. When patients say stuff, we're not challenging them on that, because actually that harms the therapeutic relationship. So we do this. We're not necessarily good, and we haven't got access to all the information, and we can't ask all the questions we would really wish to if we were to have a legal, more of a detailed role in coercion. And I think the issues are different here, because when we're talking about withdrawing care at the patient's wishes, that is quite different from actually taking life. You know, either prescribing or administering drugs to take life. They're quite separate situations. So yes, the answer is we do our best. Another point I was corrected on at lunchtime, and I would like to make the point, is that nurses have a big role in this, and often know patients rather better than I do, who might see my patient once a day on the ward round or once a month on dialysis. And so, you know, as part of establishing coercion, I would be talking about to my nurses about whether they have concerns.
It would not. I would suggest it should never be a single doctor or two doctor decision. It should be the whole team who've been looking after people. In the hospice, I also included the care assistants and the ward receptionist, because they often had a very good idea of what was going on. And sometimes the domestic staff had better information about the way families were behaving than anybody else. You need to know what's going on from everybody within the whole team.
Thank you. Mrs. Christian.
Thank you, Mr. Speaker. Baroness Finley, could I just firstly ask you to clarify an earlier statement that you said your understanding of the bill, if it became law, was that if a patient stopped eating and drinking and obviously had capacity and went through the psych evaluation, would be eligible for assisted dying in our bill. How would you change the bill to prevent that, is my first question. And then to Dr. Randall, Professor Ahmedzai, if I can pronounce his name, I'm sorry, spoke last week of morphine resistance. And could you tell us about what happens when patients have intractable pain? Thank you.
Quite simply, I don't see how you can amend the bill to mean that people couldn't stop eating and drinking to make themselves eligible. Just as a diabetic who says, I'm no longer going to use insulin, you can't legislate for that to force them to eat or drink or to use their insulin or whatever. So I don't think that you can amend the bill.
I would add, from my perspective, anyone who doesn't come to dialysis would meet who is a dialysis patient with end-stage kidney failure who doesn't come to dialysis would meet the terms of the bill as far as I could work it out. The same with any patient with a kidney transplant who stopped taking their immunosuppression. They would certainly die in less than a year of kidney failure.
Morphine resistance.
Yeah. So morphine resistance, I might defer that to Baroness Finley. She's
Yeah, okay. So it was an interesting question, because I'd have to say that I've never seen morphine resistance. I have seen situations where people, pain receptors are saturated with one particular opioid, that's a type of morphine. And the way that you manage that is by rotating the drugs that you're using. So you use a different pain-relieving drug which hits receptors differently and a different therapeutic technique. You may need to use a nerve block. You may need to use transient sedation. I think I've done it 4 times in total over about 25 years, where the patient's sedated for 24 hours. That allows their pain receptors to reset. You can lower the dose and you start titrating up again. And that's how you get on top of it. The other common misunderstanding is people talk about morphine allergy. It doesn't actually occur because it's not a true allergic reaction. It's that they've experienced side effects such as vomiting or feeling sleepy for a time or severe constipation, which is a problem. But those are managed by using the drugs differently. But my pharmacist colleague, who I think you're going to speak to later, will be able to tell you more about that.
And a final thing, I suspect rather than morphine resistance, most people just don't get enough.
No, they don't get enough.
They don't get opiates. They don't get adequate opiates. And I'm nervous about prescribing myself high dose of opiates. I would prefer that to be done in a palliative care context. So when I'm providing palliative care, I'm not going to do it as effectively as a multidisciplinary team that does that with special arrangements.
Thank you. Mr. Smith.
Thank you, Mr. Speaker. In this Honourable House last week, Dr. Jackie Davis said that, in her opinion, psychiatrists have no problem separating rational suicide requests from suicidal ideation from mental illness, and that the numbers of psychiatric assessments in Oregon have declined because they are thought unnecessary. I'd welcome your comments on that.
I'd have to say there I would straightforwardly disagree. There's an open letter from 50 psychiatrists that I think was published yesterday that went to parliamentarians in Jersey. I don't know whether it's come to you. But in that they are absolutely clear, these are professors of psychiatry, senior psychiatrists, that it is extremely difficult to separate so-called rational suicide requests from transient states. Those transient states may last a long time. People who have fluctuating mental health disorders may have periods of extreme suicidality and other periods not. But you cannot predict who is going to remain feeling suicidal and who isn't. And the only other thing that I would add, I know there was some criticism of anecdotes, but I'd have to say that the most distressed people who I have ever met were the parents of a child who'd been murdered, their only child, and they found it incredibly difficult to live with knowing that they'd let their child get into that situation. That wasn't psychiatric, and they really didn't want to carry on living. And then there have been instances where you have had parents who have jointly committed suicide when something similar has happened. But that's completely outside the scope of this legislation. But I would dispute that statement, and I think the letter from psychiatrists would support me.
I have that letter. I won't read it all because I know that time is going. But the psychiatrists have written that they say they talk about how common mental health symptoms are in terminal illness. And then they say this: assisted suicide legislation cuts a policy hole in suicide prevention by saying that some people should be helped to end their lives against an arbitrary set of criteria. And they say we are writing to express our deep concerns about proposals. These proposals should not proceed without the House taking an expert evidence from a consultant psychiatrist. We are glad to make arrangements to help with this.
Thank you. Final questioner on my list, Mr. Hooper.
Oh, thanks very much. I want to go back to the question around consent and coercion, because you've made it clear your views that isn't something that doctors are able to really address. So I'm going to read out a piece of a statutory document that the Isle of Man has around our Abortion Reform Act that doctors sign. That is a legal document that they're required to sign when undertaking that procedure. It states that the termination of the pregnancy does not contravene Section 13 of the Abortion Reform Act 2019, and the patient freely consents to the termination of her pregnancy and has not been coerced into doing so. And it's got a signature for the practitioner to sign. So is it your evidence to this House that doctors are signing this without actually being able to make that determination?
I suppose it depends what would constitute excessive coercion. You can say, are you being coerced? And the patient says no. Would that count as adequate determination of coercion?
So
I shouldn't ask questions of you, but I ask it rhetorically. Does that count as excessive coercion? In my view, that may not be adequate.
Can I just come back on that, having had quite a bit of involvement clinically with abortions? I've had particularly students, 2 in particular, who said they were not being coerced, were adamant they were not being coerced. Then after the event, one of them came and was explicit then about how she had been coerced and how she deeply regretted having the abortion. The other one admitted that she had been coerced but felt that it was all, that she didn't actually regret it, that was her career. So what you're asking is, are we calling into question the validity of your doctors in signing such a statement? And I would say, no, nobody's calling into question the validity of them. The difficulty that we're highlighting is the difficulty of detecting coercion, and that you usually detect it in hindsight.
Thank you very much. Well, in accordance with the resolution of the House, having got to the end of my list of questions, can I thank you both, Baroness Finlay and Dr. David Randall, for your time and your evidence thus far today. It's much appreciated. And with that, the House will resume business on Clause 6. And I call on any member that wishes to speak to Clause 6. If no member wishes to speak, I will offer the opportunities to sum up to the relevant parts of Mr. Thomas, to sum up on your amendments, should you wish to.
Very briefly, to move on to the new Clause 6A, about which we'll have a chance to take evidence again, I hope. Essentially, I think I'm delighted that the mover is supportive of 2 of the most important elements of my amendments, and I think a question has been raised about how this decision is taken, how the assessment process works, how psychiatrists are involved in it, and I would encourage you to support my amendment at this stage, but whatever the result, I'm absolutely sure that this needs to be looked at again as we go through the bill and in the Legislative Council.
Mr. Hooper.
Yes, thank you very much, Mr. Speaker. I haven't really heard any comment on the amendments that I've tabled, so I'm assuming that means they are all supportive. I would like to talk very briefly, I think, around Mr. Thomas's 3 amendments. I can support amendment number 20, but I won't be supporting 19 and 21. So 19 is the amendment that makes it a requirement to refer a decision to a psychiatrist, and number 21 removes the bit of the bill that talks around that opinion of a psychiatrist being provided for assistance for the doctors. There's quite a few reasons for that. I'm quite nervous about the idea of overriding the views of 2 doctors independently arrived at with the view of a single psychiatrist. That feels to me to weaken the bill. It also, I think, runs the risk of outsourcing that decision-making process to the psychiatrist away from the doctors, who arguably would know their patients best. So I think you are inherently weakening that process by essentially telling those doctors, the moment you have any concerns, you are required legally to refer this to a psychiatrist. I was quite interested to hear some of the evidence given earlier around some of the personal stories that were told, around a conversation that was had in a GP's office with a person who was seeking assisted dying, who was essentially provided with an alternative option, who was talked out of it. My concern is you won't be able to have those conversations as a doctor with patients if the moment you think something is, I'm not quite sure about this, you are then legally required to refer that person to a psychiatrist. You can't then legally have those conversations. You'd have to say, sorry, I've got a doubt about your capacity, I'm going to have to legally refer you on. I'd also refer members to some of the evidence that was submitted by the Royal College of Psychiatry to the House of Commons Committee on Assisted Dying, where they were quite explicit, actually, that the role of the psychiatrist is to assist and to provide expert opinion, and that it should not always be the job of the psychiatrist to refer. Their website, actually, interestingly, has a comment around capacity which states, any professional can test capacity, and this should be the person most directly involved with the issue at hand. So again, I think what I'm trying to get across is the idea of a mandatory referral, which then overrides the views of those two independent doctors who have independently arrived at their own view, is something that I think would weaken the bill and isn't something that I feel that I could support. But with that, Mr. Speaker, I beg to sit down, and hopefully everyone will support the 3 amendments that I've tabled.
Thank you. Mrs. Poole-Wilson.
Thank you, Mr. Speaker. I mean, similar to Mr. Hooper, I haven't heard any comment from members in the House other than, I think, Mr. Thomas, actually, about the amendment that I'm proposing. So I hope members can see why it's a helpful addition to Clause 6. I have to say, I too have read the evidence provided to the House of Commons Committee, and I would be concerned about this compulsion to refer to a psychiatrist. I mean, what we're trying to do is make sure that there is a robust process around Clause 6. And when it comes to assessments of capacity, we've already become aware from the evidence we've heard this afternoon that whilst there are undoubtedly challenges at times, and doctors and professionals already are required to make assessments around capacity, including in circumstances that could lead to a patient having treatment withdrawn. But, the concern I have is to make it a compulsion in every case doesn't seem to me to be appropriate to allowing the relevant medical professionals to make a determination in each case for the patient before them. So I would also be quite nervous about supporting that compulsion. But I don't have anything further to add on the amendment that I am proposing. Thank you, Mr. Speaker.
Thank you. And Dr. Arnson, to sum up the debate on Clause 6, please.
Thank you very much, Mr. Speaker. And actually, I'd like to thank again the witnesses who've given evidence. We haven't had that much of a debate. We've had lots of questions and evidence given to us that's made us think. And key to this clause are those safeguards, are the ability to assess somebody for capacity, make sure that they have that intent, make sure that they're not being coerced. Now, I haven't heard very much evidence about widespread coercion related to assisted dying, but I do accept that it is a problem in our society. And one of the main thrusts of the work that's been done in terms of domestic abuse is that recognition of coercion going widely within our society, not just for healthcare professionals, but widely for anyone who's dealing with other people. I also think both of the witnesses spoke about their medical education, and similarly, there was a huge amount I wasn't taught about at the time, but I know that medical education has made significant advances, especially around safeguarding, initially about child safeguarding, but now increasingly about adult safeguarding as well. And it's absolutely imperative, as laid out in the further clauses of this bill, that to be implemented properly, we need to make sure that all those people taking part in the assessments, in the process, have the adequate training, the adequate education, the adequate support, and that the general public they're giving those services to are assured by that. And I think there's a commitment, as we get further into the bill, of the amount of work that needs to be done here to implement this properly, but actually this is the right thing to do, not only for assisted dying, but for healthcare in general, so that teams can work together, can share information, both about the patient, but also about the socio-economic status of the family, so that we can make the right decisions for those patients, whatever part of healthcare or social care it may be. So with that, Mr. Speaker, I beg to move that Clause 6 be part of the bill.
Speaker.
Point of order.
It's just a question to you, because obviously I was quite surprised to be speaking first in terms of responding in respect to my amendments, whereas I suppose last when I was moving the amendments. Can you just explain to your reasoning, because obviously some points have been made about my amendments after I had a chance to respond to them?
Yes, indeed, but that is the approach that has been long held in this House, that the move of the clause as the move of the original motion will get to speak last. There's nothing new about that. There's nothing innovative about that, Mr. Thomas.
The order in which I responded. I mean,
the order in which the responses happen is the inverse of the order in which they are moved. So it was Dr. Anderson moved the clause. Someone's got to come first and someone has to come last, Mr. Thomas, and I don't intend to engage on a procedural discussion along those lines on the floor of the House. In which case, all I can suggest is that you need to refer your concerns to the Standing Orders Committee, who can review the rules. I'm just running alongside a long-established precedent in this House, Mr. Thomas. In which case, we turn to the voting, and we have putting to you first on your list amendment number 17 regarding financial motive. Those in favour, please say aye. Aye. Against, no. The ayes have it. The ayes have it. Putting to you next amendment number 18. Same practice not to include employment by Manx Care. Those in favour, please say aye. Aye. Against, no. The ayes have it. The ayes have it. Turning to amendment 19, duty to seek psychiatrist's opinion. Those in favour, please say aye. Aye. Against, no. 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 Division called. Ten votes for, 14 against. The noes have it. The noes have it. Turning to Amendment 20, psychiatrists to consider non-medical information. Those in favour, please say aye. Aye. Against, no. The ayes have... Does someone call division? Yep. Division called. (24 votes for, none against. The ayes have it. The ayes have it. Turning to amendment number 21, purpose of the psychiatrist's opinion. Those in favour, please say aye. 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 Against, no. 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 Division called. Eight for, 16 against. The noes have it. The noes have it. Turning to Amendment 22, regulations about qualifications to be mandatory. Those in favour, please say aye. Aye. Against, no. The ayes have it. The ayes have it. Amendment 23, the power to amend the form. Those in favour, please say aye. Aye. Against, no. The ayes have it. The ayes have it. And finally, honourable members, putting to you that Clause 6, as amended, stand part of the bill. Those in favour, please say aye. Aye. Against, no. No. Divide. Division called. 18 votes for, 6 against. The ayes have it. The ayes have it. We turn then to the new clause to be inserted after Clause 6, and I call on Ms Lord Brennan to move.
Thank you, Mr Speaker. Mr Speaker, I rise to put an amendment to the House to add a new clause which seeks to address what is a massive gap in policy and law. I put it to the House that it is on all of us, especially if the House of Keys is so minded to pursue a legal change to facilitate assisted dying as a service on the Isle of Man, not only to consider the model proposed, but to specifically articulate it, to be clear on it, for the record, in law, and not least for the public. Mr Speaker, there has really been very little thought, as far as I can see, or policy or explanation, as to how proposed assisted dying services, if the House is so intent on this, would be provided. That is not good enough. It is not candid enough. We cannot sleepwalk into introducing or mandating assisted dying in public health care, which for us would be Manx care. Now, we are in a very odd position as legislators from the off here, because the bill, as it's drafted, is silent on this, as in who would provide such a service. Apart from providing that DHSC can, or must, I hope, make regulations. I would suggest that it could end up being a serious abdication of responsibility just to think that some of these details would be figured out later. It is, I'm afraid, a serious misgiving to think that assisted dying is better in a healthcare environment and would be better regulated, less prone to issues and vulnerability. We've heard about some of these issues just a little this morning. Last week we spoke a little about the Liverpool care pathway, and that is an example of where services with the best of intentions can go wrong if they're not in the right model. It is perhaps narrow-minded of us to think that indeed it is more of a presumption, and I fear that we see a lot of presumption on this particular point, Mr. Speaker, that an assisted dying service, if it is to be legalised, can only be in healthcare. So, what is a comparison? Let's consider and reflect on the models of care for end of life. Well, clinical and care services which are regulated and reported on can be provided outside of public health care, i.e. outside the hospital or the GPs, and outside of government funding. They can be charities. They can provide equitable access. So it doesn't matter what your means are or how much money that you have. There are existing models of this. Here on the Isle of Man, we have hospice, and Hospice at Home, the Diana Princess of Wales Hospice Care at Home Trust. And I give these examples just for now to show the possibility of a clinical and care service model only, and things that can work on that model, which are charities that are professional, allow for equity of access, and do not get to fully rely on or rely at all on funding from the taxpayer. These organisations, such as Hospice and Hospice at Home, do excellent work, and I'm sure the honourable members would agree on that. Now, with that context of the need to define and the possibilities of a model, and forgive me, but I feel like in some ways I'm doing a bit of the legwork for the basics that I feel should have already been thought out. Let me be very clear and say that my amendment is not proposing an elite service only for those who can afford it. Such a charitable model, as proposed, outside of healthcare, could be required by licence stipulation to provide equitable access. So it could not just be for people who could afford it, could not only be for people who could afford it, as I think there is perhaps a bit of a misapprehension on that point. With that potential for a model clear, let us move briefly to regulation and reporting. The bill provides something in this respect, but by no means is that enough as the bill stands, not by a stretch. Any such provision of assisted dying as a service, if ever in place, which is what honourable members seem to want, must be well regulated, licensed, overseen and reported on. Honourable members will see that in my amendment, as well as providing for a licensed charity model, the greater requirements would be placed in terms of formal reporting, and it also specifies the role to a greater degree of the DHSC to oversee the activities in this respect. My amendment that I'm proposing requires that a safeguarding and accountability assurance framework be prepared and laid before Tynwald. These would be things that the DHSC must do. Right, so now that sets out how the role of the DHSC could look as opposed to commissioning assisted dying services as part of taxpayer-funded healthcare in Manx care. Let's get to some of the heart of the arguments about this. At the moment, there is not a stated intent that assisted dying would be a commissioned service in healthcare, which, and I have been advised to spell the arguments out about this really clearly, this is about providing assisted dying in health care. There is no stated intent, but it is clearly the presumption by many. No promoter of the bill, no supporter has spelled out what they think or propose in this respect, as far as I can tell. Nothing, not one. What have we heard? Well, I will come to that in a moment. But first, what would it mean to have assisted dying in healthcare for us on the Isle of Man? Well, if in Manx care it would in effect become a commissioned service, ultimately commissioned by government and overseen along with everything else in Manx Care, DHSC and Tynwald. How is that going? Are we so confident that we are where we need to be with oversight and arrangement or use of funding, and I will come to that too, in Manx Care, which is of course still partway through major transformation and change? Are we so confident that we are honestly saying we will ask Manx Care to deliver assisted dying within their services? Do we honestly not think that there are other basics that we should be getting right first within healthcare for the public before landing this bill on Manx Care? So, to absolutely spell it out, in healthcare for us, it would mean that assisted dying would be a commissioned service that would appear in the Manx Care mandate and be overseen somehow by the Manx Care Board and DHSC. We know that there are existing services in Manx Care that have only now just started to receive the benefit of care quality commission reports. We're in the infancy with key things already in Manx Care. Before we know it, in a commissioned service, there will probably be demands for a fully costed action plan for assisted dying in the Parliament. Are we comfortable with this? Now, let's talk about funding. Public funding. Politicians and those departments or statutory boards, for Manx Care is a statutory board run at arm's length, remember that as well, like to argue about funding. Who gets what goes where, what offers the best return, and how there is never enough funding for health and social care. Also, what savings can be made. Such debate is totally the preserve of anything in any publicly funded situation. Service X gets compared against Service Y. Demands have to be weighed. Funding, I think, Mr. Speaker, was touched on briefly by the Honourable Mover last week. I think in a query about the costs of introducing assisted dying, a point was made that costs would be offset because there would be fewer beds used up or something along those lines. Anyway, you get the point. My point is, it is an unhealthy dynamic and represents a major societal shift. We've heard this morning that it represents a major cultural shift within the medical practice and healthcare. It's a major shift to factor in assisted dying as part of the public, taxpayer, and government-funded mix. We should not want to create an expectation at state level that it is better to die than be cared for or access care in a healthcare setting. As has been said by a leading and experienced geriatrician here on the Isle of Man, and I think he puts it so well, an option becomes an expectation, becomes an obligation. Endorsement of an idea of choice in a state setting can mean it becomes a societal expectation. We should not end up bringing in or considering the economics of assisted dying in a healthcare budget funding. This needs to be as far away from NHS healthcare and Tynwald budgets and government policy as possible. The potential for assisted dying as a service in healthcare at Nobles or at the GPs absolutely heightens ethical and moral arguments and concerns. And no one is really talking about this aspect. The expectation, what we are legislating for would work in practice. We would be introducing MAID, like Canada. MAID units that form, and there are forms that you can fill in that explain how people in Canada can access MAID. Look at them. They're quite chilling, actually. It really does feel a little bit like too much of an easy reference point. It feels that making such a choices in a healthcare setting could be normalised or could actually start to feel casual, just something that's just kind of normal. This is what happens when the state facilitates assisted dying in healthcare. The great potential for exploitation and the impact on healthcare overall and the professional practice of those who work in healthcare who go there to save and to treat and to do no harm. notwithstanding a condition that may provide for doctors in Manx care to, in effect, opt out, I suppose as conscientious objectors, assisted dying is deeply dangerous for us in healthcare, not only because it would need to be a specialised service that should not be mainstreamed or mainlined, but because we have been told repeatedly by medical professionals that it will impact on what we like to phrase recruitment and retention in HR speak. But what we really mean is whether medical professionals would want to come and work on the Isle of Man. And that in itself presents a risk. We should view that impact with a massive concern for the island and listen to the medical professionals in this respect. We need these professionals here to look after our people here. Also, would we want to attract the sort of doctors who would wish to come here because of the ability to perform assisted dying in healthcare? And the point about this needing to be a specialised service outside of healthcare is relevant, Mr. Speaker, because we know that doctors and healthcare workers are not proficient and cannot be expected to identify coercion. They do not have the needed skill set. If the Honourable House is intent on this, what is needed on the Isle of Man is a quality and safe service. I cannot see how anybody would disagree with that. I cannot emphasise enough, Honourable Members, if you are serious about this, matters need to be handled in an exceptionally careful manner and treated very seriously to safeguard and protect those who are vulnerable. This does not belong in the healthcare mix. Assisted dying in healthcare is deeply dangerous. There are more arguments, Mr. Speaker, but I hope I have both set the scene, but also importantly proposed an alternative model which can work outside of healthcare, outside of Manx care and outside of public funding. The challenge will come, Mr. Speaker, as to why we are happy to potentially 100% fund with taxpayer money assisted dying, but not do that with hospice care or palliative care. So, why back my amendment and vote to keep assisted dying outside of healthcare? Well, doing this would try and hopefully help address recruitment and retention concerns regarding nursing, medical and ancillary staff for Manx care, when 74% of doctors oppose the bill and 34% would consider leaving if it becomes law. Assisted dying would then not need to become part of the mandate for Manx care. A further reason is because it is a criminal and professional disciplinary issue to encourage suicide in the UK at present, and there is a risk that, if this bill passes, UK doctors and doctors rotating through posts on the Isle of Man may face sanctions for actions considered criminal in the UK if they are involved in assisted dying here or advising the UK. Separation of the assisted dying service from Manx care would mean that doctors and other professional staff who rotate through the UK Manx postings as part of training would avoid the possibility of falling foul of different laws in the two jurisdictions and subsequent professional disciplinary investigation or criminal proceedings. The amendment would allow for the DHSC to ensure the standards and monitoring through a licensing process, and perhaps only one pharmacy would be involved. There are reasons too for it to be a standalone charity. Only 25% approximately of hospice funding comes from the Isle of Man government taxpayer funds. The government should never give the impression that it prefers assisted dying over palliative care by funding assisted dying more fully than hospice. Having assisted dying provided by an external charity would put it on par with palliative care and could perhaps be supported in some way. It would mean that only health professionals who wish to be involved could be. It would mean that any agency would not need a large premises. The service would not be integrated in some of the ways we've heard this morning, as most deaths would probably occur at the patient's home. It would mean that the professionals involved in assisted dying would be independent from Manx care and have no vested interest in encouraging uptake from within an NHS position. Finally, No agency or company would stand to make a profit off people using the assisted dying service. So, my challenge to those who are supporting the bill, if honourable members are not persuaded by some of the arguments here for a proposal for a safer, more accountable model, then my challenge would be somebody needs to be upfront about what is being proposed. Mr. Speaker, my amendment brings some clarity to the parameters here and what might be possible. And whilst it is recognised that no amendment can make this bill safe, my amendment is welcomed by Manx Duty of Care, who are particularly interested in safeguarding the vulnerable people in the face of harm and have been representing the view of hundreds of healthcare workers on the Isle of Man. My amendment is also supported by the Isle of Man Medical Society, who have been voicing concerns, and I remind honourable members of the letter received by Tim Ward last autumn, which was signed by some 155 health and medical workers working in a clinical setting. 57 of them were doctors. To remind honourable members, some of the points that they made in their letter to us in October last year relates to why the practice of assisted dying in healthcare becomes difficult. They make the point that their recent survey of doctors on the Isle of Man by the Isle of Man Medical Society had a response rate of 61% of all doctors. A huge majority of 74% think the bill would have a detrimental impact on healthcare here. It states that a staggering statistic that 1/3 of doctors would consider leaving the island. This would spell disaster for the Isle of Man Health Service. But their views accord with many other views put out there by the World Medical Association and the Royal College of General Practitioners, amongst many others. They pointed out to us then, and I have to say it only really was put into context by the evidence given this morning, that the suicide prevention would be compromised. When you spell out some of the things that may be a momentary wish that could actually be needing of help rather than seeking to terminate or help somebody terminate their life, I think that does start to make sense in a much more fuller way. They make the point that the island benefits from an excellent hospice and we don't need to legalise suicide and euthanasia. So they put the point to us, Mr. Speaker, about the difficulty this proposed legislation puts to us. They've highlighted that as an island we rely on attracting people to come here to work in healthcare or return and choose to practice on the island. They have made it clear that if we are interested in advancing with this, it will impact the island's ability to recruit a healthcare system promoting assisted dying. We are putting them and their profession in a terrible position if we ignore their concerns, and I thank them for all of their efforts and their representation. I would also like to thank people, in particular constituents and others who have written to me to show support for my stance on this bill and the amendment, which I bring somewhat reluctantly because I don't think that this should be going ahead on the Isle of Man at all. But if it is to go ahead, it needs to be done in the right way and very carefully. We should keep assisted dying out of public health care, as it may bring a sinister and complicated dynamic into the mix in the future, and we must take our responsibilities very seriously. It alters the societal expectation. Is it cheaper? Is it better? Am I less of a burden? What about the vulnerable? What about the growing cost of care? What about palliative care? It is staggering, Mr. Speaker, that some of this has not been thought through, and we are actually not clear on this point about how a service might work and who would deliver it. Mr. Speaker, it is true and it's correct that this can all get a bit emotional, but that should not deter us from proper examination. And actually, if it causes emotion, there is probably a good reason for that. Mr. Speaker, I beg to move the amendment in my name to keep the provision and facilitation of assisted dying out of healthcare, and if members are so intent on this, at least provide for a proper licensing regime, take public funding out of the mix and add to oversight and reporting. There is a better model than the non-model or implied presumption before us, Mr. Speaker, and I think the House of Keys need to deal with this. Let's not proceed blindly. We cannot afford to get this wrong.
Thank you, Mr. Speaker.
Honourable Member Douglas Central, Mr Thomas.
Thank you, Mr Speaker. I beg to second and reserve my remarks.
And Dr Allinson.
Thank you, Mr Speaker. I fully respect the Honourable Member's consistent opposition to the principle of assisted dying and her representation of her constituents' views. But I rise to oppose that this new clause be part of the bill, both on the principle of trying to remove assisted dying from other forms of end-of-life care and in terms of the practicalities of implementing these restrictions, which I consider to be completely unworkable. Firstly, this new clause introduces the principle of effectively removing the provision of assisted dying from mainstream healthcare and mandating that no professionals involved are permitted to provide any other forms of care within the health service. This would be a departure from all other assisted dying laws around the world. There is a great benefit to ensuring that assisted dying is an end-of-life option alongside others, as it allows for a full and proper discussion between a doctor and their patient as to the care and treatment that is available to them. Dying people should have the right to talk about assisted dying with a doctor who is familiar with them, the Manx healthcare system, and all the other forms of care available to treatment at the end of their life. By requiring a doctor to operate entirely independently of the Manx Care Service and our NHS in order to provide assisted dying deprives the patient of any continuity of care. It also calls into question how the independent doctor is to access medical notes to confirm the underlying diagnosis or access scan and blood test results, as subsection 7 forbids anyone working in Manx Care or our NHS from even providing administrative support for the service. Would they be allowed to provide bereavement counselling for families who requested it after an assisted death? The stipulation that such a service can only be provided by a charity which cannot accept funds from outside the island would mean that the only option would be for it to be a considerable cost for accessing such public health care. In Switzerland, assisted dying is provided by charitable organisations such as Dignitas, but even Swiss doctors involved in assisted dying are not prevented from providing other forms of palliative care, and there are in fact efforts being made to better integrate assisted dying and palliative care in Switzerland. It's also difficult to see how this new clause satisfies concerns regarding the safeguards in place to protect people from pressure or coercion. Doctors are already trained to do that within the current healthcare system. This amendment would remove layers of oversight and isolate the practice in an entirely new system that no other jurisdiction in the world has adopted. Secondly, on the practicalities, I do not believe it would be possible to provide assisted dying under the terms of the new clause. In their recent correspondence to members, the British Medical Association expressed their view that assisted dying should be organised through a separate service that would accept referrals from other professionals or self-referrals, but this would not necessarily mean the service should be outside the NHS. The BMA supported the development of an opt-in system for healthcare professionals, which would give doctors the greatest amount of choice about whether, and if so, the extent to which they were involved, ensure that those who wanted to participate had the proper training and expertise to do so, make it easier for patients seeking assisted dying to identify a doctor willing to help them, and make the service easier to audit, which the BMA believes would help build confidence and maintain public trust. In the Isle of Man, annual deaths are approximately 800 to 900 per year. Using the proportions of deaths under assisted dying laws similar to the bill's restricted proposals, which are normally about terminal illness, such as Australia and the American states, we can expect between 4 and 13 assisted deaths per year are likely under these current proposals. Even accounting for the number of consultations that might take place with terminally ill people who do not go on to have an assisted death, it's unlikely that any service could provide assisted dying with the sole and exclusive employment of the necessary healthcare professionals. And we heard earlier from Baroness Finlay about her comments about Canadian doctors who exclusively provide assisted dying. I completely understand that some doctors do not wish to be involved in assisted dying, and this is why there is a robust conscientious objection provision in the bill. Equally important, however, is that doctors who wish to be conscientious providers of assisted dying are supported to do so. The survey from the Isle of Man Medical Society showed that 1 in 5 respondents indicated that they would be willing to participate in the assisted dying process. Evidence from other jurisdictions shows doctors' willingness to participate increases year on year when laws have the chance to bed in, so we can expect this figure to rise should this legislation be passed. In relation to the General Medical Council and their relationship with assisted dying, I think they've been quite clear that where doctors were providing it in a jurisdiction where it was legal, they would be satisfied that as long as those doctors complied within the guidelines of that legislation, that they would not be jeopardising their registration with the GMC. Surely it is essential that the Manx public are reassured that doctors and other clinicians involved in assisted dying were knowledgeable and highly trained, highly skilled in the end-of-life care. There would undoubtedly be a negative impact of removing these individuals from the health services entirely, which this new clause requires in order for them to provide assisted dying services. Reducing the pool of highly skilled clinicians in end-of-life care contradicts the shared wish on all sides of the debate for all dying people to have access to the best possible care. Mr. Speaker, I find that this clause would confine the provisions of assisted dying to the shadows, it would weaken safeguarding, governance and transparency, and hamper the education and support, including that of grieving families. With that, I wish to oppose the bill, stand part of the clause stand part of the bill. Thank you, Mr. Speaker.
Honourable Member for Rushden, Dr. Hayward.
Thank you, Mr. Speaker. We've heard evidence from our witnesses this morning about the need for continuity of care for patients, the need for access to records, and actually that's remarkably easy on an island this size. We can't lose them too far, it turns out. Perhaps much easier than it is in the NHS across in the bigger island, and the need for all professionals to be involved in detecting coercion. We heard about the need for receptionists to be alive to so that you'd see that family dynamic that was created. This amendment would in fact create a private provision, clearly delineated away from Manx Care and any of their staff, with no assistance from things like pharmacy services. So you'd have to set up a separate pharmacy in order to provide the medications that would be needed. And on islands as small as ours, with the limited scope that this service would need, that's clearly unworkable. I note with some irony that the proposed charity would exist to relieve human suffering, but that's what this bill is trying to do, but in a seamless, state-provided and compassionate way that doesn't put financial barriers in the way. And I suspect that a charity would almost certainly have to put financial barriers in the way. Our hospice is indeed part funded through Manx Care, so we do already fund an element of palliative care, and so is hospice at home services. So it's incorrect to claim that charities don't operate or operate at the moment without that support. And in fact, I don't think that it's possible to claim that charities could deliver the regulation, oversight and reporting that this move seems to require.
Point of order.
The Honourable Member give way, or is it a point of order?
I didn't state that. In fact, the amendment proposes that DHSC would do that in a fuller way. You wouldn't get the charity to do the regulation itself. They would be subject to licensing and regulation requirements by DHSC. Thank you.
Thank you. Charities are under certain regulatory objectives anyway,
I know that,
aren't they? So I think, but that sits outside of what DHSC normally sees. So I regret some of the points that are raised in this debate around the cost of dying. I hoped we weren't going to go down this route. We already provide end-of-life care, we provide feeding, we provide medication, we provide nursing to get to a natural death from a terminal illness. That might indeed take longer than anyone opting for this pathway. I don't think cost should come into the consideration, but I suspect, if anything, this would end up being cost neutral to Manx Care. So, honourable members, I'm not going to support farming out this provision outside of Manx Care and our established regulatory framework. The opt-in provisions that have been proposed to allow healthcare professionals to put themselves forward to provide this pathway, I think, provide enough safety. And it's clear to me that having services provided by a charity would create vested interests that we've been warned about. I'm not going to be supporting the amendment today because I believe will create a situation where the assisted dying that we seem to want to support can't be practically delivered on our island.
Mr. Morehouse.
Thank you, Mr. Speaker. This amendment really does concern me. Unintentionally, it has the potential to be a wolf dressed as a lamb. I have asked previously about the role of Manx Care, and receive no answers. This isn't the answer I want. If a resident is close to the end of life and can't access euthanasia through Manx Care, then this really does create new issues. It also raises the possibility of pricing being involved. And if we've got those two things in place, then we aren't going to have equality of access. The mover certainly fought hard and made reference to hospice in an attempt to provide some reassurance. But Dignitas is a non-profit organisation, and they charge around £15,000. If that was to happen here, there will be no equality of access. From my perspective, if the amendment succeeds, there's a real danger that we're going to be in a position of some people who really did hope to have access to this not having access to it. We've seen in medical cannabis a lot of people did expect that to be available through Manx Care. It's something that's to be paid for, and it's a different model that many people haven't considered. If we can't provide a safe, low-cost solution for the people, then I'm even more concerned about what we're going to end up with at the end of the day. There's also a positive that if Manx Care does take on this role, there's going to be a greater reluctance for future people to bring in legislation that would expand the range of the offering. Because if Manx Care is going to actually struggle to provide this, there's going to be a real reluctance by politicians that come after us to expand what is on offer. Thank you, Mr. Speaker.
Mr. Thomas.
Thank you very much, Mr. Speaker. Just to make sure my understanding is correct, I'm not actually taking the opportunity to make the remarks I've reserved. I'm just moving a procedural motion.
It depends what it is you're going to say next, Mr. Thomas.
I'd like to follow up my email to all members, polite email to all members yesterday, explaining that I would like to move into Committee of the Whole House under Standing Order 4.4a, so we can take evidence from Baroness Finlay and Dr. Randall, as I wrote to all members about yesterday, to hear their evidence specifically about the new clauses.
Ms. Edge.
Happy to second that.
I will second that. So, procedural motion, Mr. Thomas, quite in order, under 4.4a, to move that we hear from Baroness Finlay.
As discussed this morning as well.
Okay. And Dr. Randall, to take evidence. You hadn't applied a time limit. Is that your intention, Mr. Thomas?
No, 1 hour should easily be sufficient.
Just so that the House has an element of expectation is all. Now, does anyone wish to speak to that motion? Mr. Glover.
Yes, I do, because starting off with the guidance that we had this morning, it was clear that Clause 6 and new Clause 6 were being treated separately, and certainly while we've been taking evidence this morning, I have reserved asking the questions that relate to new Clause 6, so I think it's only fair we have that opportunity now, having respectfully followed procedure throughout the day, to be able to ask those questions.
Mr. Speaker, can I just ask a point of order?
Point of order.
A couple of members already indicated they would like to speak on this particular motion being moved by the Honourable Member from Glenfaber and Peel.
That's right.
So if we started bringing witnesses into this, should we not deal with the matter at hand first and deal with the motion that's been tabled and allow members to speak and then call witnesses?
Well, it's well with Mr. Thomas is well within his rights to move at any point in time that the House resolves itself into committee. It's up to members to take that or not take that at any particular point as well. Where what would happen is if we go into committee when we came back, the list continues. So people who had not previously spoken would still be eligible to speak, but those who had spoken would not be eligible to speak again because it's not an amendment. We're taking evidence in a committee of the whole. So I hope that explains the concept of what Standing Order 4.4a is intended to do. Next to speak in this debate, Dr. Allinson.
Thank you very much, Mr. Speaker. I thank the Honourable Member for bringing this procedural motion, but I think it's very important that the Honourable Members in this House agrees whether, in principle, this clause should be part of the bill or not, before we then go on to take evidence and then debate the bill.
Order. Dr. Allinson has the floor.
And for that reason, I don't think now is an opportune time to take evidence on this new clause. I think we have talked previously for over an hour and a half about a whole range of principles regarding this.
No.
But obviously this is up to the House to decide. It is a procedural motion, but I shall not be voting for it. Thank you.
In which case, the motion...
Might I speak briefly?
Thank you.
I'm assuming this procedural motion
where we are?
is
Adam?
I think you already announced that the motion. You already began announcing the motion.
You did. Here. You did.
Mr. Hooper.
Thank you. I'm actually going to propose an amendment to the motion, actually, because I do think that I missed the original bit of the debate, but I'm assuming it is framed along the same lines as the earlier motion to take witnesses for an hour in general terms. Actually, up to an hour. So I actually have no objection in principle to that. I agree with Dr. Allenson. It will be better after the House has resolved whether to pursue this clause in principle or not, because some of the detail in the clause is actually quite interesting. But I'm happy to, if that's the way the House wants to go, but I'd like to propose actually that rather than the very loosely worded procedural motion we had before us previously, we narrow it down a bit. I think if we are going to question witnesses, it should be a proper questioning session with the ability for us to actually respond and interrogate witnesses to cross-examine, for want of a better phrase. I don't really think
that's the right word.
That's the way a committee...
Strong language.
Order. Allow Mr. Hooper to have the floor.
That is the way that committees work. If you sit in a committee, for one of our scrutiny committees, for example, it is a discursive process. That is the whole point of a committee system. Allowing members to ask a question and then hear, as we did last week, a 28-minute answer is not overly helpful to this Honourable House. Actually, a question and answer session should be a question and answer session. I think that's definitely more beneficial for us as a House to get more information out of our witnesses. It gives them the opportunity to express views on a wider range of topics rather than a narrow area of questioning. And I think it also allows members to get clarity. We saw earlier a number of these subsequent questions that were asked by members were seeking clarity on things that had been said earlier. Mr. Callister's, for example, asking a question saying, I wasn't quite sure what you said or what you meant. That is the purpose of saying we should have a much more discursive evidence session if we're going to have one at all. So that's my proposal. Exactly the same as was originally suggested, that we question the witnesses for up to an hour, but it be in a much more discursive and like in a much more proactive fashion, rather than the one question, one in and out process we've adopted so far, Mr. Speaker.
Democracy will ask everyone.
Did you just question the...
My concern is I'm not entirely sure how I can enforce rules around that should not previously prescribed in standing orders or in the honourable member's motion. So, with the best will in the world, I'm at a bit of a loss to how to maintain a common set of expectations of the House around how to do that. So I'm struggling to be able to work out a way to put that amendment to the House. Ms. Lord-Brennan, you wish to speak?
Yes, please. Just to say, I think it was already trailed and flagged earlier this morning about the idea and the timing of going into a committee session after I'd moved the clause. I think if some people, the honourable promoter of the bill, is trying to say, actually, no, let's not have that now, and let's just quickly, try and conclude the vote. Well, I wonder why. What are you worried about? What are you worried about?
Do you remember give way just briefly? So the comments that I thought were made earlier was about exactly that after you had moved the clause. So far you have not moved the clause. Procedurally you have moved the clause in principle. Following that you then moved the clause. So that's what I anticipated would happen, would be after the clause itself had been moved, as the honourable member quite rightly outlines, we would then take evidence. But the clause has yet to be moved. This is a procedural technicality of which Mr. Speaker is a big fan, but that was the clarity I was trying to get.
I would point out in standing orders the clause has moved twice, once in principle and once in detail. Ms. Lord-Brennan has moved the clause in principle. Now, I give the option for anyone else to speak before I give Mr. Thomas the opportunity to sum up the debate on the procedural motion.
Thank you very much. And I just wanted to remind people and Mr. Speaker that I did actually write at 15:27 yesterday answering exactly the question that Minister Hooper quite rightly has just raised. So the purpose of hearing the witnesses by resolving into a committee of the whole House is to answer questions on the case to assist dying only to be given in accordance with the licence and without recourse to public monies. I can't make it any clearer. That's what I'm asking to be able to chance to take evidence on.
Thank you. So I put the question to the House that evidence be taken from Baroness Finlay and Dr. Randall for up to 1 hour in respect of the new clause. Those in favour, please say aye.
Aye.
Those against, no.
No.
Aye.
Position called. 16 for, 8 against. The ayes have it. The ayes have it. Do you have a point of order, Mr. Glover? Or are you just looking to put a question down and get in early?
Early.
You're getting in early, right. It's very wise. However, I will give first shout to the mover, Mr. Thomas, and Mr. Glover, you'll be hot on his heels. In which case, Mr. Glover, your early indications prove worthy.
Guru Mayad Lauder. With this new clause 6, as prosed by the member for Peel and Glen Faber, in your view, what would be the benefits of moving this service outside of Manx Care and to a registered charity?
Thank you. I think the clause has been very nicely introduced, actually, outlining some of the benefits, and I will just stress them as I see them. When you look at the message that you are giving to your population, you're saying we're going to 100% fund a service to end life out of your taxpayer money, but we're only 27, and forgive me, I think I said 29 previously, it's only 27% funding your hospice services. So, in other words, if you put a value judgment on that, I don't think it's very difficult to see where you're placing your priorities. We know anyway from Canada that the Canadian government have estimated how much money they've saved from their health service by having this as part of their health service system, which I also think is not a very good motivation for running a service where you end life. In terms of your numbers, I would dispute your numbers. I'm not sure how you got to 4 or 13, because if you've got 800 to 900 deaths a year, if you go at the lowest level at 1% or up to above 5%, which is what happens in many countries, you would have between 8 and 45 such deaths a year. So I think you have to be realistic about the numbers that you can expect. You talk about having 1 to 5 willing GPs. Well, I can't see how, from the way this is written, that stops those GPs working in their own time completely outside the current Manx provision. They do their Manx provision work in their own time separately, as a separate contract. They can contract with this service. The way that the mover of the bill was summing up, talking about end-of-life skills, it made it sound as if he was expecting palliative care to provide this, when it's absolutely clear that your palliative care service here do not want to be the providers of this. So you get round that problem by having it in a separate charity. Their accounts would be open and viewable. In Switzerland, Dignitas, I would remind you, do not publish detailed accounts. We do not know where all that money goes, and it's difficult to see how come they charge so much. You've already heard about the sliding scale that could be applied, so those who are well heeled contribute in, and those who have no money are actually funded by the service, and you can do it with a gradient, rather like a cooperative type arrangement. I have it as a separate service with clear documentation, and this would be a service for the assessment and the delivery of this assisted suicide and euthanasia service. It would in no way inhibit the conversations between the doctors and the patients, having open conversations, because I hope that they all do that already and have open conversations with their clinicians. I'd be astounded if your palliative care team don't have open conversations with people. There's absolutely no reason why you can't provide bereavement counselling. I hope you provide bereavement counselling already, and the GP and those who know that family would provide longer-term bereavement counselling. It might also involve the school, for instance, if there are children who are still at school. The safeguards in place, you would be able to make sure that this group were licensed to provide this service, had been trained in the criteria that you determine in your secondary legislation, in your regulations. And you would also then be able to say that perhaps they would do this for 3 years with a further 3 years renewable, so that you don't get people inured. You don't get
the boredom of the repetitive failure, which we've seen happen in other branches of healthcare. In England, there's just been a really damning report published about maternity services, and there have been damning reports over the years about other services where people just become a bit ritualised to a process. You don't want that. With those numbers, you're nowhere near the 500 plus a year that I was talking about in Canada. So that's just a distraction to refer to the Canadian situation. This is a relatively small number of a described service. If you don't have it as a separate service, what you're doing is you're asking Manx Healthcare to mark their own homework. Like this, you have an independent service that you can audit and look at. And it allows people to opt into it, and it allows all parts of the system, that would include a pharmacist who could opt in, to provide those drugs. And you're not a huge area, so actually you could have one key pharmacist as well to provide it. So I would say those are the advantages. I think it provides you safety, but I think it also gives a very strong message to the public that you are concerned, that they want to have this service as far as you can ascertain. I know there are disputes over the public consultation, which was below half wanting it and then a further one. Who knows where the truth in all of that lies, but you're giving a commitment to provide a service, but you're doing it in a ring-fenced way that you can really audit and control it. And we know from other countries around the world, I've already told you about the failure to report, the incomplete reports. In Oregon, their official documents, their official annual reports show the number of blanks that there are on the forms that they get. We know even in the Netherlands, which are well set up, where they have SCEN doctors and they have a reporting system and an oversight committee, even there, confidential inquiry led to revealing that probably 20% don't get reported. So you would have a much safer system, and you could actually leave the world with a safer system.
Thanks. I would endorse everything said there. You'll know from my previous comments that I don't believe assisted suicide and euthanasia can ever be safe, but there's no question in my mind that this amendment makes it substantially safer, and I would strongly commend it to you. And it seems to me eminently achievable, and I would point you have to decide the issues of the funding, but I'd point you to the model of provision of abortion services in England and Wales, which are done almost entirely in third sector organisations. In the UK, that is publicly funded but carried out by third sector organisations. It seems that this is an eminently achievable solution.
Thank you. Mr. Hooper.
So I'd just like to ask a couple of questions about that interaction with the public-private. So you said there wouldn't be anything that prohibits a GP, for example, a Manx Care GP, providing these services in their spare time. The amendment actually says the person specified in subsection 5 must not be employed by or engaged to provide services to Manx Care or be otherwise engaged to provide services mentioned in the National Health Service Act at the time they exercise functions in the Act. So that would be a statutory provision on a Manx Care GP doing anything of this in their spare time. There's also a bit in the Act that says no other person who is employed or engaged to provide services to Manx Care or who is otherwise engaged to provide services mentioned in the National Health Service Act may provide administrative assistance or other support in relation to the performance of functions in this Act. And so again, the issue of alternative sort of supplementary support services like counselling would be excluded because that would be other support in relation. So this amendment actually quite explicitly says you either work for Manx Care or you work for this charity. So from my reading of this amendment, there's a clear delineation between the two sets of services. If that's the case, how do you envisage this being set up when it would require its own diagnostic, pharmaceutical, specialist input, because nobody undertaking any of those roles for Manx Care or the Health Service, but they would have a statutory bar based on subsection 6 and 7 of this clause from engaging in any services connected with the provision of assisted dying. That's what the bill, that's what the amendment in front of us says in black and white. So how would you envisage an entirely distinct service being set up that cannot in any way utilise bank or locum staff, Manx Care resources for diagnostic procedures, testing, anything like that would be outside of scope, because this amendment is pretty black and white on that, actually.
You've already heard last week that there's no thought that the people doing the assessment would be repeating the diagnostic tests.
they would be relying on the information given from the multidisciplinary team and from the GP notes and the hospital notes, and possibly any treatments in England. So the assessors will not be undertaking diagnostic tests. They may be going back to say that these have to be done. If I'm hearing you right, you're saying that any GP or any health professional employed by Manx Care is unable in law to undertake any other extra work whatsoever.
So just to clarify, Mr. Speaker, that's what the amendment says in front of us. It also explicitly says that no one engaged can provide administrative assistance in relation. So in terms of provision of those medical records, for example, Manx Care staff could not provide those medical records to a private doctor because subsection 7 explicitly prohibits that support. So I just want to be clear, those two subsections, that's what all I'm talking about, is what the amendment does in those two subsections that are in front of us in this new clause.
Could I suggest that if that is the legal advice that you've obtained, that you could very easily just amend that to allow them to work in their own time, not as part of the work where they're being provided by Manx Care, because actually to amend that clause would not be difficult at all. In fact, I'd be happy to suggest some wording to you if you wanted, but it's probably not appropriate in this committee.
Ms Edge.
Thank you, Mr. Speaker. It's around this really, because obviously honourable mover of this clause and of this bill was very clear with regards to the doctors and the relationship with patients and being familiar with the patient and everything about the patient. So if this new clause was to come in to the bill, taken on board what Mr. Hoop has just said about Manx Care workers in any way. However, they do already have opportunity to work outside of our Manx Care system, a number of our doctors and staff, so that is an option there. If it was to be amended, I feel from what I've just heard that would be accepted by the challenger of that amendment. Anywhere else you've seen this, you said that we'd be the leaders within this if we went down this route to make sure it's outside of our health service. What is there anything else that you think to try and encourage other members to consider this, that another amendment could come forward? There's nothing to stop an amendment coming to an amendment. Is there anything else that could hinder that from the medical profession and their regulatory bodies?
You'd be, in a way, providing something along the lines of a Dignitas type service, because that's outside healthcare. People travel from different countries to go to Dignitas. They have an assessment there and they have their life ended there. So that there are already models that keep it outside. In the Netherlands, they have a separate euthanasia service which operates quite separately to the GP and their SCEN doctors. So there are models that you could pick up on quite easily as you look at to make regulations. And I think all you would need to do would be to say that they weren't undertaking the activities for which the licence is issued as part of their employment or engaged in providing services to Manx Care or otherwise engaged, so that you would allow them to, in fact, you could call it moonlighting, you could call it working in a separate sector or whatever, but you would keep it completely separate from their normal duties as a GP, as a hospital doctor, as a hospital nurse, a hospice nurse, community nurse or whatever, or as a community pharmacist.
Thank you. Mr. Collister.
Thank you, Mr. Speaker. We know from a presentation that was given to honourable members that 48% of the island's population goes through hospice. It does a fantastic service. And for that reason, I don't think it's fair or right that we compare that service and the delivery of an excellent service to potentially this clause and to this piece of legislation. Because, as I say, it's a massive amount of the population go through that. My concern about this new clause is the fact that this is privatisation of a service. And what I really want from yourself is I want your proper opinion and assessment, and I want a guarantee from you that none of my constituents in Onken will face a 10,000 bill or a 15,000 bill to access this service, because I can't see, unless you tell me differently, how you're going to raise the funds to run this service. So please explain to the House and the public listening how you intend to raise the funds for as a charitable organisation. But secondly, that my constituents will not be charged £10,000, £15,000 to access service if they need it in the future.
Firstly, let me reassure you that no one's asking you to set up the service and run it.
Agreed.
I presume it's a hypothetical question.
But it needs cast iron. These need to be discussed.
Order. Can I suggest, Mr. Collister, that that's a guarantee that you might need from the move of the amendment rather than our witnesses here today?
Well, I'd like, Mr. Speaker, I'd like some reassurance before I support this clause.
Well, again, I think that reassurance needs to come from the mover. And what we are hearing from the witnesses who have expert knowledge in this field, and they can't, I think, give you a guarantee or an assurance, but they can give you their opinion based on their expertise.
I would suggest to you that given that you only 27% fund your hospice services, which 48% of your population are accessing, you've already effectively gone out to a private or charitable organisation to provide that service. You have no control over the salaries that they award, I presume, or what they do or their activities. So you've put it outside. But leave your hospice services separate. You're going to set up a separate charity. Charities, how do they raise money? They raise it by donations of different types. People will spend huge amounts on funerals. They spend sometimes £8,000, £12,000 on funerals. Well, I don't think this service is going to cost anywhere near what Dignitas have been charging. And you could work it out quite easily on a sliding scale. And if they have a huge amount of money, then they might have a slightly smaller coffin and a slightly smaller hearse and a slightly smaller funeral that's less expensive if that's the route they want to go down. That is their choice. That is how they choose to spend their money if they decide that that's what they want to do. You were asking about choice earlier, and I'm suggesting that choice also involves a choice as to how you spend your money while you're still alive on what you feel that you'll need towards the end. Now, I hand over to Dr. Randall because I think he's got some comments.
Well, just very briefly, I mean, point 2 makes it clear that licences can only be awarded to a charity. There's still scope as to the terms of those licences, and one of the terms could be that they provide services free at the point of access. So if charities want to provide this, they will need funding, and people will need to give to them and support that. That can be a stipulation of their contract, so the licence that's awarded.
And this is a privatisation of services.
Right. Order, Mr. Collister. I think you've had. Thank you, Mr. Thomas. You're next.
Thank you very much. My question is about the regime, the regulatory regime, the licensing regime. Am I right in thinking that the people working in this service as proposed would still be under the General Medical Council, pharmaceutical body, nursing equivalent body? Am I right in thinking that the licence would cover all of the regulatory? Am I right in thinking that the coroners would still apply equally to this situation? How would, please could you answer those questions?
Yes is the answer. Of course they would.
Yeah, you can't provide medical care outside those.
You have to have a GMC licence or be registered as a nurse or whatever.
So you would become an employee of this charity for the work you're doing for them.
Thank you very much.
Remain professionally registered to whichever body.
Could I just make the additional point that actually the group Dignity in Dying are not registered as a charity because they campaign, but they do have an offshoot which is a charity, a registered charity, and that certainly gets a lot of money in. It isn't. They're not in financial difficulties at all, and they've never been asking for additional money, and they provide a lot of services to patients, not charged for.
Thank you, Mrs. Bubb.
Thank you. I just wondered, following on from some of the questions that have already been asked, whether you believe that a person of one of the following categories, be that assisting health professional, attending doctor, independent doctor, registered nurse, registered pharmacist or registered psychiatrist, so those that are listed within this proposed new clause, could meet their revalidation requirements if they were engaged solely in the work of the charity that's proposed under new Clause 6, given the prohibitions that do exist in Part 6 and Part 7 and the residency requirement that's specified in Part 8. And then I wonder also how a single speciality focus with limited exposure, given the projected numbers we would have on the Isle of Man, would affect their competency, especially where we already have some challenges around small patient cohorts that limit the opportunity to maintain competence due to our small island status. And I mean, to declare my interest, I've worked as a nurse on the island for some years now.
I don't see how this would impede your revalidation at all, because you're revalidated on the job that you are then doing.
And you believe they could get the adequate clinical hours? So 300 for a year for a nurse.
You have a lot of people who do no direct clinical contact at all, such as those working in public health and so on, and they get revalidated.
But
order. I'm conscious that we would try not to get into sort of supplementaries. But if you want to come back later, I will put you back on the list, Mrs. Barber. Mr. Hooper again.
Yes, I want to talk about the regulatory regime that's envisaged by this clause. So the clause is explicit that no public monies can be expended in any way, shape or form. But the clause also talks about an appeals process through the courts, which from memory are publicly funded. It talks around the Department of Health and Social Care setting up a regulatory and oversight regime, which again, from memory, we are publicly funded. So the question I've got is, how do we set up a regulatory regime without recourse to public monies, as the clause specifies?
Well, later on, within your proposed bill, you are going to be setting up an oversight and review system. And that is in a later clause. Forgive me, I can't remember which number it is now.
I appreciate that. Again, if I could just clarify. Clarify, there is a line in this clause that we are talking about that explicitly says no public monies may be expended. So whatever the bill later says, this clause itself would place an additional stipulation on us that says you cannot spend public monies. So my question to you is, if we cannot spend public monies on our proposed regulatory regime, how do we fund our proposed regulatory regime?
I would suggest it doesn't say that. It says no public monies may be expended in assistance of dying.
Yes.
Under the Act. It wouldn't. You can spend money in overseeing it and ensuring the regulations. You can't spend it in directly ending the lives of patients. So I think
that's interesting.
Well, order. Mr. Glover.
Thank you. You mentioned in the previous session about Harold Shipman and how difficult it is to stop serial killers within healthcare. So I just wonder if this new clause here, how we can ensure the process in this new clause is rigorous, and should the coroner always report on these deaths?
How do you ensure the process is rigorous? Well, you would know who was working in it. You would know the applicants who had come forward. You'd be able, with your oversight body, to look at all of the records and see how those assessments were undertaken. As far as I recall, your bill doesn't actually propose that they are all reported to the coroner at the moment, but I can see that coronial oversight might be helpful, or you've got your scrutiny body that you're going to set up, which would report, and I would suggest should report annually, because if you wait 2 years, you might have things going wrong and you don't detect them soon enough. But it should report annually and provide all that data. And this service, this charity set-up, would be responsible for providing full reports with all of the details, with the patient details completely anonymised. But you would have the demographics and the diagnosis. In an island as small as this, you might even want to anonymise, certainly, ages of people, because that just might become identifiable. But it's quite easy to do, because you could put them into age brackets or whatever for reporting.
And again, I'd point to the UK abortion oversight committees where they do this, and where the numbers are very small, you can use aggregate figures and so on to maintain anonymity. But I think when you're talking about licensing here in point 2, that would need to be the terms of the licence, that these charities are willing to engage properly with whichever coronial oversight system you see fit.
Ms. Edge.
Thank you, Mr. Speaker. I'm more concerned around the sort of governance and the practicalities. Obviously, the Honourable Mover of the whole bill was clear on the local radio this morning with regards to that a person can choose a place that they wish to die, so they can die at a place in their time and their choice, and we have heard mention of it at people's homes and that. So do you feel that because it is that choice, that helps it to be outside of Manx care and our services? Our services are so stretched anyway. Do you feel that supports that more because our services are already stretched? So if they can have a time and place of their choosing, I'm not sure where that could be, and I'm not sure that's nailed down as yet. But I think that's a really important point that needs to have your view of.
Yes, I very much agree with that. And I also think that this, having it provided by a charitable organisation, would deal with the BMA. The BMA wrote about conscience provisions and an opt-in system for staff. That it would deal with that very nicely as well, because healthcare professionals would decide whether or not they want to work for such an organisation. So I think it would be very helpful in that regard.
No, I would agree. I think it'd be extremely helpful because these people could spend as long as that person and their family needed without being aware of the pressure of other patients who they're not seeing because they're tied up with this case.
Mr. Cannon.
So I just want to just be clear on the principle of what you appear to be supporting. I mean, we heard this morning with Clause 6 that's gone through now that effectively we've changed the way we view doctors. Now they're no longer just the givers of life, but they're also now the takers away of life under the legislation. That social contract with our medical professionals is fundamentally changed under that clause. What you're saying is actually now, because of the confusions in the legislation and the amount of confusion we've heard from the medical society about the amount of doctors who are actively willing to engage in this process, we don't really know who the prescribed doctors are going to be. I won't know whether it's going to, if I'm the candidate, I won't know whether it's my doctor or another doctor. I won't know potentially who that independent doctor is. And effectively there's lots missing in the legislation in terms of, what would happen in the event that both doctors disagree as their appeal process, etc., etc. But this potentially, accepting there may be some requirement to amend, but this potentially offers effectively a mechanism to professionalise, more so regulate and have proper effective reporting around the process with committed professionals outside of that care environment, so that we are not continuing to add that pressure onto already hard-pressed doctors who want to carry on promoting the ethics of life. And by doing so effectively, we are really going to create this environment where it is properly regulated, overseen, commissioned, and that we allow the healthcare service in its whole to carry on giving life to people and to stop confusing the medical professionals about their responsibilities, and more importantly potentially bring clarity to the patients. Is that fundamentally what you're talking about?
People have coined the term euthanasia-free zones, keeping healthcare a euthanasia-free zone. Under the terms of this, patients who really wish to access assisted suicide or euthanasia could do that, but patients being treated in healthcare would not have to have that question hanging over them, and staff working in healthcare settings will be protected as well. I think I remain completely opposed to the legalisation of assisted suicide and euthanasia, but I think if you're going to do it, this is the way to do it.
You also, by doing it like this, avoid the problem of staff who are, if you could call it secondarily peripheral, so nursing staff on the ward, care assistants, trainees, pharmacists, you've got pharmacy assistants, other people perhaps working in their shop who have really strong conscientious objection, but you don't have anything in here about objection by place, conscientious objection by place. You only have it by individual, and it's only directed at, as I read it, at the doctor.
and you get around all of those problems because you take it completely separate, as you just explained, from mainstream healthcare. So I also do not want, I do not want to see the law change, but I'm a pragmatic realist, and as a parliamentarian, I've learnt that there may be things that you don't like, but you have to look at the best option of what you have in front of you. And the option to take it separate seems to meet many of the concerns without falling into a problem of a downward spiral. It would protect the patient, the family, and your healthcare staff. It would also protect your message to the public that you're giving over how you spend your money and your hospice services.
Thank you. Mrs. Barber.
Yeah, thank you. I wondered how you would envisage the smooth referral into such a service for an eligible person by a professional, given that they would be expressly prevented from being a part of it because of the way this is worded, and how you'd view a conscientious objection clause working in this regard, given the reference you had just there to a assisted dying free zone or similar.
I'm sorry, the idea is that this service would undertake the assessment.
How do people get to it? They have to refer
Well,
themselves?
they speak to their GP, or they can self-refer, or they can make inquiries themselves, and the service would probably have web information as to how to go and apply to it. But they would inform the clinical team that they're working with that they were going, and this service would be expected to ask the clinical team to access the information, the clinical information relevant.
And again, you know, I don't know how it works here, but in London, all abortion care is self-referral. Patients access care themselves, and then if there's a need for communication about notes, that happens subsequently. But the clinical team then takes it forward.
Mr. Hooper.
So I want to talk a little bit about legal jeopardy. So we had quite a bit of evidence here last week from a UK barrister who specialised in medical cases, and he talked a lot about grey areas and legal jeopardy and the risk of doctors not doing certain things because they weren't clear themselves on where the lines were. So you've talked there about you'd be able to refer from a GP or share information or share diagnostic reports. I mean, the clause in front of us is explicit on that you can't. But one of the things that the witness last week talked about was that doctors may be reluctant to share information for fear of breaking the law. So, for example, in this case where the law would say you cannot provide support or services or assistance, if a patient told you, I want these records or I want this test because I'd like to access assisted dying, that doctor would say, I actually can't do that test for you because I know it's going to be used for assisted dying, and that places me in legal jeopardy. That was the evidence that we heard last week from a UK barrister. So I'm just after your views on that, as to whether there's any real validity in that argument, that actually would a clinician, say based in the UK, refuse to provide a diagnostic scan for a potential cancer, for example, if they knew or suspected that the patient was using that or would use that to access an assisted dying service in the Isle of Man. That's the assertion that was put to this House last week. I'm just wanting your views on that, really.
It's the patient's data. So ultimately, patients can request their data and it's theirs. Periodically, I have a cohort of dialysis patients I look after. Periodically, people write to me to ask me for information about them. I ask the patient, are you happy for me to share this information? If the patient's happy, I share the information. I don't see issues here. If there's issues with the wording of the clause, I wonder whether it's worth passing the clause, the principle, and then come with some amendments to it. But it seems to me that this is the right way forward, and if there's a few bits that need to be tied up, then that needs to be done subsequently.
Mrs. Paul Wilson.
Thank you. Yes, I just wanted to. I think it's important just on conscientious objection that the wording talks about a person at the moment, so I think it captures everyone, not just a doctor or anybody else in our bill. But just on this point that a few others have talked about, the new clause expressly says that assistance in dying under this Act may only be given pursuant to and in accordance with the provisions of a licence under this subsection, and others have referenced some of the barriers that exist now in this subsection about not being employed by Manx Care, not being able to provide assistance. And I think I heard from you earlier on the importance ultimately that the patient, the individual, is given the signposting, is able to have a full conversation with their doctor. And I'm just concerned, I suppose, that if that's what matters ultimately, that the patient, the individual, is able to have a conversation and then be signposted to another part of care. Effectively, this clause would prevent that. I think the other thing is, because it's a person who provides any assistance in accordance with this Act later on who is not guilty of an offence, effectively anybody outside this would still be guilty of an offence. The risk is that we set up within the Isle of Man the problem that we've heard of already about practitioners not being able to give advice or any assistance whatsoever when their patients choose to go to Dignitas because they are at risk themselves of facing liability under the law. So we're creating a carve-out for some. Well, that's what the clause.
I mean, I would be delighted to discuss with any of my dialysis patients if they wanted to talk about going to Dignitas. I would have that conversation with them. I would actively welcome that. I would want to explore why they're feeling that way, whether there's things that we're doing wrong that we could address. What support they've got, what plans they have for the future, what means of independence we can provide them with, and all of those things. I would actively wish to have that conversation with someone. If after all of that and putting things in place and involving the multidisciplinary team, if they still feel that way, sure, I wouldn't be referring them to Dignitas. But if they needed some of their medical notes, that's their data. They're entitled to have that.
First of all, what this is proposing is that you carry on providing all care, and you would have a separate service that could run in parallel so that people could move across to it, but their care would continue. Not that they'd be dropped out, not that people would do a U-turn on the care that they're providing. They would still carry on trying to improve their quality of life, which is what they need to do. In terms of Dignitas, I've had patients who spoke to me about wanting to go to Dignitas. We've spent a long time talking about it. And one person, in the end, the conversation went that, look, if you're going to travel and yet you wanted to go on a certain type of holiday, why don't we get you on that holiday first and then you can decide whether you go to Dignitas. And we provided him with all the medication and all the guidance of what to do in every eventuality, and he had that lot. Actually, he did go on the holiday, but at the time he could have just gone off and gotten a plane to Switzerland. He was clearly going to travel somewhere, and in the end he never did go to Dignitas. He just went to the beach and had fish and chips, and probably that was his last meal, but he never went to Dignitas in the end. But you're talking about a system in parallel. There's nothing in this amendment to stop people having an open conversation. Yes. At the moment, people don't have open conversations through, I think, a false fear that listening to patients' concerns could somehow implicate them. There's nothing that says that you can't listen to all the concerns that your patients express, use open questions to really discover what's going on and what they're really worried about, what they want to achieve, and so on. And I don't see how this would stop that happening.
Ms. Edge.
Thank you, Mr. Speaker. It's really on patient records, and I'm just wondering what your view would be, because you've stated that patients' records are theirs, they own them. What would your view be if it was down to the patient at initial access to an external service to bring along what records they felt, and then they get verified and checked within that external operation outside of Manx Care?
I think it's going to be very individual. If you're in England, you'll have the NHS app, and on the NHS app you'll have all of your results and all your records, and you'll have all your blood tests and everything. So I recently had a consultation with a consultant, was asked for things. Couldn't access my Welsh notes, but my English notes were all available on my app. They're all there. I don't know whether you've got the NHS app here at all or not. You're nodding that you do have. So the patients have got all of those, and it'll be each individual patient going to this service who will explain, discuss things, be assessed, and it will depend on that service as to what they ask for. But the advantage for you in oversight is you will know what's been asked for because it will be recorded, rather than the current proposals, which is effectively two doctors
quietly behind closed doors, with no monitored discussion, no documented discussion, agreeing or disagreeing to provide lethal drugs to somebody with no oversight of the way those assessments are conducted.
Mr. Canham. Sorry? Ms. Edge?
Okay. Are you aware of any countries that have got a contract with Dignitas to allow individuals to go to Dignitas and no consequences when they arrive back in their country? From a medical professional.
Certainly not a contract with insurance. No.
No.
But if you look at the guidance on prosecution from the DPP now, it's very clear that actually people shouldn't be prosecuted if they have accompanied somebody to Dignitas or provided information on going there. And they have done it in good faith, having tried to dissuade the person from suicide. There have been some prosecutions. I think there have been 3, but forgive me, that might be the wrong number. But actually they were proven to be of malintent. They were homicidal.
Ms. Edge?
So therefore we might have been quicker to just do a bill that would be to make sure that couldn't happen to an individual or anybody involved in an individual going off to Switzerland. Just a point.
I can't see how, unless you introduce a new prosecution policy, that somebody providing information to this charity would be subject to prosecution.
It would be under the Act. Yeah. I've reached the end of my list. So I'm conscious that we allowed an hour. I've had just under that. Someone care to move that the business be resumed?
Oh, yes, please, Mr. Speaker.
Do I have a second?
Yes,
please, a second. The question then that business be resumed. Those in favour, please say aye. Aye. Against no. The ayes have it. The ayes have it. We will then resume the debate on the new clause, and next to speak is Mr. Hooper.
Mr. Speaker.
Do you have a point of order, Mr. Thomas?
No, just to speak. Registering to speak in the debate.
No, that's Mr. Hooper, you're next.
Thank you very much, Mr. Speaker. So I have a lot of issues with this clause. I mean, I'm quite concerned that it is essentially privatising an aspect of healthcare, and this is healthcare, I think, whichever way you want to think about it. That worries me, in principle, actually. But I want to talk a little bit more in detail around some of the things that are inside the clause itself. So firstly, Mr. Speaker, I'd like to give notice that if the clause is approved in principle, I would like to give notice of my intention to amend it, because the clause, as currently worded, is entirely unworkable. I would like to actually congratulate the Honourable Member for bringing a part of this clause forward, because it acknowledges, I think, for the first time in the Act, that provision of assistance under the Act is to be treated as the relief of human suffering. I think that is a big step that's actually probably missing in the Act, but it doesn't explicitly call that out anywhere else. This amendment is the first time, I think, that we've seen that particular turn of phrase used and that particular turn of phrase called out. But I would like to flag some concerns here. I'm concerned around creating a discontinuity of treatment if Manx Care staff are not allowed to participate in any way. And I think that's what subclause 6 and 7 quite explicitly does, alongside the prohibition against expenditure of public money in this Act. And just to be clear, the clause actually says no public monies may be expended in assistance in dying under this Act. Clause 7 of the bill is entitled Assistance in Dying and includes regulation-making powers for the Department of Health and Social Care. So it is explicit the Department of Health and Social Care would not be able to make certain regulations under the Act because they're in a clause called Assistance in Dying, and assistance in dying support is prohibited by this amendment. This is relatively straightforward stuff. The amendment itself also talks around placing a number of other restrictions on medical staff. So the inability to share records, I think, is a serious concern. It is quite concerning that you won't be able to share information or support or staff. Actually, all of these things are problematic. I think it's problematic that you need to develop your own pharmacy for this. You wouldn't be able to utilise an NHS-funded pharmacy. All of our pharmacies on the island provide NHS services. I'm not aware of an entirely private pharmacy on the island. So that, again, would have to be set up. I'm also a little bit concerned around some of the comments around legal jeopardy and prosecutorial discretion that have been referenced. I think honourable members in this House will be very well aware of the risks with prosecutorial discretion around the prosecution of medical staff on the island. Oh, yeah. We had a big particular issue last year which I'm not going to go into detail on, but it shows quite clearly the risks that can be faced by medical professionals when there are grey areas in the law, which this amendment would create. It would create a very big grey area in terms of what medical professionals are able to do and what they're not responsible to do, and what they're responsible for, especially because failing to provide assistance in accordance with the Act would be a criminal offence, because essentially it is attempted murder, which is the argument that I've made myself. So the reality is this amendment does create criminal offences for medical staff operating on the Isle of Man and does not provide them with the legal certainty that I think they need if they're going to be providing this service. So it does absolutely need amending if it is going to be supported. I'd also like to talk about some of the detail in the clause, really. So I've already touched on subclauses 6 and 7, which are very specific as to what the NHS cannot do, and subclause 9, which explains quite clearly public monies may not be expended in assistance in dying under the Act. Again, they're quite clear. There are some technicalities, I think, around here. So there's a reference in here to people providing the services must be resident in the island when they exercise functions under the Act. The bill doesn't define residency, it defines ordinarily resident elsewhere, so there's a terminology difference there. I'd like to understand what the mover meant by must be resident in the island. What is her vision for that? I'd also like to have an understanding of how people providing the services may be paid, because they may not receive funding from outside the island. Fine, I know issue in principle with that. We're a small place, we don't have scale, so our local branch of Dignity in Dying, for example, is unlikely to be raising significant amounts of money to fund this service, and they wouldn't be able to access UK-based resources. But the bit of that subclause that concerns me most is the section that says the charity may not remit monies off the island. How do they pay people who don't live here? So if you have a specialist, for example, flying in to provide a particular service, they will be resident on the island at the point the exercise functions. Can you pay them if they're taking that money back with them to the UK? I don't know. Can you remit money to UK trusts, for example, NHS trusts, in terms of some of the diagnostic work that may be undertaken, or laboratory work, for example, that may be required? If I'm a specialist service providing a specialist diagnostic function, which again would need to be entirely separate from the NHS in this clause, can I pay a private provider in the UK to do that for me? The answer is no. I may not remit monies off the island. This clause is very restrictive in terms of how it actually works in practice. I'd also like some more detail on the proposed licensing and oversight regime that is anticipated. And I speak to this now with my kind of Department of Health hat on, in that it seems to place a significant amount of additional oversight on the department to almost come up with a licensing regime from scratch. I'm not aware of a regime like this that exists anywhere else in the world. This would be a uniquely Manx phenomenon. So I would like to understand from the Honourable Mover what she envisages that licensing regime looking like, some detail behind it, some policy behind that regime, how will it work in practice, where will we take best practice from, for example, or is she going to allow me as the Minister to simply write what I feel like? That would be a bad idea, I would suggest, Mr Speaker. So I just think there's a lot in this clause when you get down to the detail that is really problematic. I appreciate the intentions behind it. I personally think it should be a separate service, but within the NHS, very much in the same way that hospice is currently supported. It is a charity, but it is supported by a significant amount of public money, £1.7 million this year, up from £900,000 at the start of this administration. So we are making significant strides, increasing investment in our palliative care service in hospice. But ultimately, that's a model that could work. You could have a charity that is partially supported by public funding that is outside the NHS, but that is not what this clause proposes. This clause proposes a complete and entire separation between the health service and this service, and so I don't think that works in practice. So I think we need a lot more detail behind some of the proposals in here, especially around how this organisation may be funded, how they may pay staff, how those staff may be regulated, the impact for this on individual staff, and I would like some clarity on that legal jeopardy and the prosecutorial elements of would doctors risk being prosecuted under this if they do some of the things like share data, provide diagnosis, undertake work, because then they would not be acting in accordance with the Act, which would then make their actions potentially a criminal offence. So I just want some clarity on some of this stuff, because it hasn't really been touched on, and actually it is really important, if members are going to go ahead with this, that we understand this amendment, as it's currently worded, it presents real problems and real challenges, I think, to get this bill into operation. Thank you, Mr Speaker.
Mr Johnston.
Thank you, Mr Speaker. And I sort of stand to oppose the retention clause and certainly very much believe that the importance of having that inclusive health system as part of a core of what we're trying to achieve with assisted dying. I think what sort of drives my support in principle for assisted dying has been there from the start, really, and I've mentioned it before, but I think it's important and is where the law fails people. I think that's something that we notice, and so what is ethical and moral about several hundred terminal people in the UK taking their lives every year, which means the proportion there'll be some people in the island who do that every year. And probably more worryingly and more difficult, especially for the families, is those who try but fail. And where's the law for them? So surely having in law assisted dying that allows healthcare professionals to have that open conversation with all options on the table, that is part of an inclusive health system, which would actually have the potential to reduce suicide rate, because that terminally ill individual can have that open conversation with a health professional that may well completely dissuade that person from any form of assisted death and seek palliative treatment. And I'm very struck for what Dr. Randall mentioned this morning, the conversation he had with a patient who was very minded to that view that they actually wanted to end their lives. But through that conversation, completely changed their view. I think the argument could be that actually the best result of an assisted dying law is nobody accesses assisted dying, because it actually drives people to have that open conversation which is not happening at the moment. So I'd argue that full openness and inclusiveness that includes assisted dying as part of that discussion option is the moral and ethical thing to do going forward. Thank you, Mr. Speaker.
Mr. Gollister.
Thank you, Mr. Speaker. Just with regard to the new clause, I still feel this is privatisation of the service, and I think my honourable colleague from Ramsey has outlined very eloquently some of the points and concerns that many of us have in this chamber. But I do want reassurance of the mover of this particular new clause, how much it would actually cost somebody to access this service. I think it's absolutely clear. If you're asking us to support this new clause in this bill, which will privatise it, I want to know very clear how much somebody can expect to pay to access a service. If you're not able to give me that answer today, then I can't support the amendment. Thank you, Mr. Speaker.
Mr. Thomas.
Thank you very much, Mr. Speaker, and to the mover for the reasons I'll come to in a moment. The first point I wanted to say, though, is that I fully agree with Minister Hooper, the Department of Health and Social Care Minister, because the mover might have got this clause wrong. The whole point of an in-principle debate of a clause is for us to have an in-principle debate of the clause. I think Minister Hooper's actually stood up a bit too early, because I think we all have the right, after the new clause has been passed, to just cite Standing Order 4.8 bracket 5, which is to say we need time to actually draft amendments, and that's the situation I have been in for some time. I haven't seen this new clause with sufficient time to move my own amendments. There are some sensible things that have been said today that have inspired some amendments that I want to bring. Minister Hooper, the Minister of the Health and Social Care Department, has obviously got some amendments that the government would like to bring to this this new clause.
Just a point of order, Mr. Speaker, I'm not aware that government has a particular view on this.
I see. It's just always very hard to tell. I didn't give way, actually. I didn't give way, but it's always very hard to tell. So thank you very much for that clarity. Basically, Minister Hooper kept talking about details and technicalities, and I'll come to those in a moment, but that's exactly the point of having a two-stage procedure where we first of all move in principle, and subsequently we give everybody a chance to look at it for longer and to look at the detail and to look at the technicalities and to find out how it would work. So if I just take the controversial clauses, 5 subsections, sub-clauses, 5, 6 and 7, that all depends exactly what the functions are under this Act. It all depends exactly what we mean by the services mentioned in the National Health Services Act. There's plenty that I want to do more research about, as I'm sure the Department of Health and Social Care and Manx Care would like to do, and that's the whole point of having this legislative process. To treat it differently, quite frankly, is to continue to embarrass ourselves in the way that we're treating this very important matter. So it's not fair to ask the Honourable Mover of a new clause at this stage to provide us exactly the costing, especially as the Treasury Minister is the one who's some
idea.
Who's moving this.
Well, we don't know how it's all going to cost.
Order! Mr. Thomas has the floor.
So therefore, that's a very important point to say. Today we're debating the principle of this new clause. We've heard from our experts, from ourselves, from government ministers that this is we should move on to how we're going to do this, if we're going to do it. And that's the first compliment I wanted to give to the mover, because as the mover said in her opening remarks, how this is to be done and how we're going to solve these real problems and how we're going to deal with regulation and how we're going to deal with staff retention and how we're going to deal with a licensing regime for approved substances for this regimen, and all those practical issues are the ones that we really should have thought about previously, but now, at the very least, we should be thinking about them now. And what we've got on the table is an amendable new clause to help us do that before we put things into law for the future. We've got to remember, we've got to respect ourselves. We are the democratically elected branch of the oldest continuous parliament in the world, and we need to do things right. And we don't want to make, it's not about rush, it's about doing things appropriately for the Isle of Man. Yeah. It's about doing things appropriately for this very important thing on the front line of medical ethics and that sort of thing in the British Islands. Another Minister, Mr. Barber, the seconder of this motion, made a really good point, which is there are huge implications from being a small island with only a small number of people who die each year from the economies of scale. And that's something we've practically got to think through in terms of practical delivery. Legislation's all very good, but legislation follows policy in answering these practical questions. It's not all about, I'm for choice and it's my life. It's about practical. It's about practical measures. It's about not creating expectations that can't be fulfilled. It's about doing things right. It's about not worsening our reputation with a repeat of our anaesthetists, court case and so on, as was being hinted at. It's not about those things. It's about making sure we're in a good place to stand up for ourselves as a parliament that's actually done things the right way. So the whole issue about the licensing process, tackling some of the important issues that the mover made in her opening remarks is one that I want to think about, because to me that's incredibly powerful. We have private operations delivering huge amounts of public funds, which is difficult under the bill as currently proposed, but it's something that's very interesting. We had £18 million approved outside the February budgets for a private firm to come in and do eye and knee and so on operations. The hospice operates for 73% of its activities with funds from the very generous Isle of Man community. We have all sorts of areas that are being considered for effective privatisation in our health service at the moment. So this is a really important issue that we need to look. I had a very clear answer that this makes this safer, because all of the regulators that help us in terms of substances, people, processes apply across into our island the same as they would otherwise. And to me, in closing, it deals with two very important issues that I've been wrestling with the whole way through this process. The first one is the whole business of what professionally trained medicine-type people have been telling us all the way along, and what they say about how this will affect them and how this will affect their jobs, and that should be first and foremost in all of our minds as we go forward. There's nothing unusual about the Isle of Man in this. Apparently that's the same that people are wrestling with throughout the world. There's always seems like a difference between the medical view and the public view, and so we've got to make sure we get that right, compounded, magnified by the fact we're in a place with only with limited facilities in any area, and all of the issues with staffing and keeping your qualifications current because of the limits to where you can work in the Isle of Man. And the second issue is that whole issue of moral hazard for the state. So I think one of the brilliant and genius things about this amendment today is we get to the heart of what the state's trying to do with its suicide prevention strategy and what it's trying to do with its healthcare regime, and somehow separating out to that the other difficult issue, which is providing choice to people outside the state tasks of healthcare and suicide prevention and mental health and all of those sorts of things. So they're the two issues that I'm still wrestling with as this bill goes through, and I really do hope today that we give ourselves the chance to get to the heart of this incredibly important how we do this by giving us a chance today to vote in principle on it. And then we've already had two people now say that they want to come back with amendments. So that gives us a chance to work up some amendments. And what's the alternative? The alternative is that somebody else, or somebody, even yours truly, would come back with another new clause later way through the through the bill, which will be different from this one, and we'll go about debating it again. So we're better off from capturing what we've got, voting in for this new principle today, and then actually working with what we've got. The alternative would be another new clause to debate, which would be different from this one, otherwise it wouldn't be allowed.
Mr. Glover.
Gurumai Lauder, and firstly I want to thank the two witnesses that we've heard from so far. Very much appreciate the fact that you've come to our lovely fair island. And how ironic, people on the other side of this debate are wanting clarity. That is something we've been seeking right from the very start of this debate and haven't gotten, have been lost in the fog of debating this, and I'll leave it to the mover of this amendment to actually blow away some of the smoke that's been blown her way, and let her deal with that. But I think we do need to take our time with this and get things right, and this, to me, does offer a little bit of a more workable thing. But the main takeaways, I'm just going to point out what we've heard from the evidence today, that in relation to the clause we were discussing earlier, unworkable, it's bad legislation. We are legislators. It is incumbent on us to produce the very best legislation that we can. Exactly. That is our role. So at the moment we're being told this is unworkable, and whatever way and side of the debate you're on, we need to wake up and smell the coffee here and get this as workable and as best legislation as we possibly can. And we've heard it's based on Canadian law, which has widened legislation to include those that are not terminally ill and to those with serious mental illness. So let's bust this myth. There are no safeguards that are going to be in place here that we can guarantee. It's hard to spot coercion, we've heard. It's hard to diagnose a terminal illness with certainty. We've heard of bad practitioners. We've heard it's bad for Manx care, with many doctors and medical practitioners against this concept. And it's a major change, and it is a major, major change to society and the way we think and view death. So this separation, to me, eases that last problem somewhat, because we're taking it away from Manx care and government assistance and the suicide prevention strategy, and we are setting up something new. It's a concept. Why not have something that is unique to the Isle of Man? But just because it's not done anywhere else in the world, are we therefore not allowed to actually do something and try and establish something that could become a precedent and a real marker for the rest of the world? Let's be brave if we're going to bring this in, and I admire the fact that the mover has brought this in. It is a brave move. I look forward to blowing some of the smoke that's been thrown her way by some of the contributors later, but I welcome this and will be supporting it.
Mr. Cannon.
So we are moving to accept this new clause in principle, and it has been an intriguing day, because what we've done today under clause 6 is effectively change that social contract that exists, and I've said this before, that exists between the state and its people. We've asked effectively our doctors now to not only administer the medicine for life, but we have effectively now, under clause 6, asked them and authorised them to act as independent doctors and indeed to act as not only an independent doctor, but also as a excuse me. Can somebody help me out? Just bear with me 1 second.
Need a phone a friend.
To act as licensing doctors, and those doctors may or may not be your GP, but they simply have to be doctors that are willing to administer the necessary or undertake the necessary assessments for an individual to be administered the pills that they need to cease their life. Now, this is all quite generic stuff. We have no idea. We've heard from the Medical Society that some 35% of the medical professionals may choose to cease working in the service if we pass this legislation. We don't really understand what the impact will be on the medical professionals. We don't really understand how many medical professionals will or will not choose to conscientiously object to this legislation, will or will not participate. A terminally ill person will not know whether or not his or her GP is going to be part of this process. And there is very little in the way of licensing and regulation in the legislation as it currently stands. What this new clause has done has brought into play the opportunity for us to properly license and regulate the service delivery and to separate it from that healthcare service itself and to remove, I would suggest, from many of our medical professionals engaged solely in the delivery of life and the provision of extending life, remove from them that confusion and fog that may exist around the service that is also being asked of them to deliver that to terminate life. And we've heard from some proponents today, from Mr. Hooper in particular, that in principle this clause has got merits. Now, admittedly, it needs some improvement and it needs some enhancement and it needs some amendments, and it's clear a number of issues that have been raised today mean that members would have the opportunity to do that, but it is also clear that this offers us the opportunity to properly regulate and license assisted dying in such a way as to provide clarity for our medical professionals and to remove from them that confusion and that additional pressure which may now apply to them, given that this House so far has indicated that it is willing to change that social contract that exists between the state, the medical professionals and the very people who access the healthcare service. So what we're doing now effectively is assessing valuable information that has come to light regarding this concept that has been put forward today in this clause. There is clearly work to do, and there is clearly the capacity and standing orders for us to do that work if we take this forward in principle. It is the first opportunity that we have to really get into the detail around the licensing and legalities and the regulation that we will need to make this work successfully, both for the patient and for the healthcare service. It offers us real opportunities to improve the legislation, whether we do or do not support it in its whole. So that is the position, I think, that has been made clear today, both from the evidence that's already been given, when you factor in the approval that we've already given to Clause 6, and the indicators that have come from so many members that there is the opportunity to amend this now to indeed make it a better service for everybody. So I will be supporting, in principle, the new clause.
Next on my list, Mr. Peters.
Thank you very much, Mr. Speaker. If this additional clause was intended to provide an additional route for people requiring assisted dying, I'd absolutely be in favour. Since it doesn't appear to do that, then I'm afraid I'm not. Private healthcare can work well alongside charities and the NHS, and I expect that this would also be the case with assisted dying. And just a quick point, if I may, Mr. Speaker. A number of people have mentioned Dr. Harold Shipman today. He was GP to both my parents, who, even after he was convicted, believed him to be a wonderful GP and a caring man. 2 days before he died, my father said, I wish Harold Shipton was still around. Thank you, sir.
Mrs. Paul Wilson.
Thank you, Mr. Speaker. And I also agree that the moving of the new clause in principle has opened out an opportunity for further debate and consideration about a range of issues that are very, very important as we progress the bill before us. One thing I would like to begin with, though, I think is for us not to lose something that I think a number of us referenced at the very beginning of the debates in relation to this bill, and that is compassion. And I do worry that in the way we start to debate some of the detail here, that we lose the common and the shared concern of all of us here, that when we think of individuals, when we think of those we represent, what we're all motivated by, I believe, and what I think the witnesses who we've heard from and everyone who is participating in this has at their heart a desire to listen to people but to be compassionate. And I think I would prefer that we weren't characterising our debates in this House on this very emotive and sensitive topic in terms of sides. I think it would behove us better to talk about what we're trying to do to support people and be compassionate, and to then be thoughtful in the way that we reflect on the evidence and the information before us. I think also I'm acutely aware that when it comes to matters of suicide, and I've listened very carefully to the evidence today and to those who've spoken before about the complexities when somebody receives a terminal diagnosis, and I think it came up in the evidence to the House of Commons Committee as well, that shock and that initial reaction to a terminal diagnosis can trigger a whole series of questions and reactions, and that suicidal thought processes may arise in that context. But with support and the opportunity to have conversation and so on, it may be possible for people to find another way. I'm also aware, though, that when people have got to a point where they are clear that they are dying, that what they are seeking is a good death. So when we are talking about people who are already dying and who have had all the support, and I could not look at this bill, as I've said before, if I didn't believe that we had excellent palliative care in the Isle of Man, that we would continue to promote and support excellent palliative care. But I recognise that for those for whom that may not work, and for those for whom they get to a point where they no longer feel there is provision for them to help them have a good death, this bill provides a choice for them to have a good death. And I would distinguish, therefore, that position from the very, very important work under our suicide prevention strategy, which is to help those who are without hope, not seeking a good death in a situation when they are otherwise already dying. I think my issue with the new clause is what we are seeking to approve in principle today. So what I have heard in large part so far, certainly from the mover but also from other contributors, is that this is about wholly separating out the provision of this service from our existing health services. So is that what is behind this new clause, that it should be entirely separate with all the challenges that will go with that, as have been pointed out by the subclauses 6 and 7, and the issue around no public money? Or are people actually wanting to discuss in more detail the operation and oversight that is available under this legislation? Now, if it is the latter, that's a matter we all ought to be concerned in. But we haven't got to clauses that are coming forward in this bill later on around an opt-in provision. So the Honourable Member for Aaron Michael has talked about witch doctors. Well, if this House supports an opt-in provision, then we will know who is going to perhaps register and be willing to provide this. We haven't talked about the fact that there's a proposal to change Clause 9, for example, to make sure that there is proper guidance and training. And I absolutely listened with interest to Dr. Randall today talking about the position of a junior doctor faced with the most difficult situations. Well, within our power to make regulations around qualifications, why wouldn't we specify that the providers of this type of service shouldn't be the most junior people at the outset of their career. On the contrary, they should have had a level of experience of dealing with difficult situations, of seeing and trying to understand coercion. So I suppose my point is the new clause being moved in principle has allowed us to reflect more on all of these issues. But I would also say that we have other clauses in the bill and indeed other amendments coming forward which I think are designed to tackle some of these issues that we are trying to make sure we get absolutely right, so that if this service can come in, it comes in with all of the safeguards for all of the protections and provisions that we would desire. I think I'd also just say that with the Honourable Member Ferrer and Michael, I think, talked about Clause 6 asking our medics to take part. I completely disagree. It allows for those who may choose to opt in due course to offer this service, but it would never force anyone, because we have a conscientious objection clause, and indeed I have amendments in my name that seek to strengthen that, because I fundamentally agree that we should never be in the position of overriding an individual's conscientious position on this topic. I'm also intrigued by the fact that we've heard that this potential new clause, or the principle of separating everything out, might make a difference to our medics who say they would no longer wish to be on the Isle of Man. I do slightly struggle with that. Either people are fundamentally against the provision of assisted dying, however it's provided, or they look for the most appropriate way in which to provide this service with the best interests of our patients, of the people who will receive this service in mind. So I don't necessarily, I'm struggling to see why separating out the provision of this service should make such a radical difference to people who otherwise would have concerns. What I would prefer is that there is a more integrated approach, but actually we deal with any concerns around regulation, training, monitoring, all of these very, very important things. We deal with them appropriately through other clauses that are available to us in the bill. I also believe that if this House supports an opt-in provision, that's how we will overcome confusion, because it will be absolutely clear that people have opted in and can and should be properly regulated and offered training and guidance. I think also I don't quite accept that if we separate everything out, as might be envisaged by the new clause, that the state somehow has no part in any of this. That wouldn't be true, honourable members. The provision of assisted dying, however it is provided, has to be subject to regulation. I think all of us would accept that. The state is inevitably involved, quite rightly, in regulation. So I welcome that this has been moved. I think it has opened up a wide variety of debate. I'm not sure that I can support in principle today, because I think there are other ways to try and tackle some of the issues that have been raised, and there are a variety of amendments already proposed that seek to address some of the issues that people rightly are raising. Thank you, Mr. Speaker.
Thank you. Ms Farragut.
Goramaya, Lorida. I share some of the concerns expressed by other members already about this proposed new clause, proposing that the provision of assisted dying is taken out of the remit of the health service and that it should be provided under licence to a as yet non-existent charity, has a great deal of potential, I think, to place our residents at a disadvantage in their final days if they should wish to have an assisted death. So firstly, any charity will need to raise funds, and the simplest and most obvious way to do that would be to place a charge on services. End-of-life care should be able to be provided to all residents, not just those who can afford to pay. In her opening remarks, a mover made comments that not a single member can describe the process from start to finish via Manx Care. So I do think it's reasonable to ask how this proposed amendment will work from start to finish, and including the very basic question of how much this will cost for the people who wish to access it. I also strongly believe that this service should be directly under government oversight. Commissioning the service to a charity removes it one step further away from this. And indeed, in response to some of the comments made by the Honourable Member Ferrer and Michael, Mr Cannon, Chief Minister will be pleased to learn his government is progressing at pace with improving legislation around the regulation of health and care services, with a new regulation of care bill coming later this year, which should hopefully address some of his concerns around regulation. perhaps honourable members will agree with me, that we are striving to create an integrated health and social care system which is regulated by the Department of Health and Social Care to provide the very best seamless care for our residents, and creating yet another arm's-length service will prevent further challenges to this. There seems to be potential that other types of oversight will be missing also. For example, it's not clear if the doctors would be operating under the governance of the General Medical Council and other governance that sits around NHS and hospice staff. The discontinuity of care mentioned by other members is also a big issue, and that specifically, subsection 7, takes the provision of assisted dying away from Manx care and explicitly prohibits Isle of Man clinical staff who would be familiar with the patients who are seeking assisted dying, from accompanying them at their end of life. Lord, I'm unable to support the proposed new clause in its entirety. Thank
you. Mrs. Barber.
Thank you very much, Mr. Speaker. I just wanted to touch briefly on the mention of a change in the social contract between healthcare professionals and patients. And I don't see this as being the case actually with this legislation at all, and that's me having worked in a number of areas where I've dealt fairly closely, if I'm honest, with people who have been at the end of their life, whether that be people coming into accident and emergency in times of crisis, whether that be intensive care, whether that be hospice, or whether that be in nursing home care. And I've always felt that I'm part of that team who've been able to talk to patients and talk to families, to be there at the time when we explain that there's not anything more actually that medicine can do for that person. Whether that be that we talk about their options in terms of what palliation there is available to them, or whether we talk about the fact that actually we've got someone who's on life support and we're now going to withdraw that support and we're going to turn that machine off. And I think it's right to say that actually that's never an easy conversation. And I've always been incredibly humbled by the many reactions that people can have actually in those discussions, those really difficult and challenging conversations that we have, sometimes which people are expecting, and sometimes where people have been blindsided by something that's happened that they didn't expect to happen, and they haven't had that opportunity to prepare for at all. But I absolutely go back to the point that talking about death is a good thing, and we should be doing it all the time, not just in those times when things hit a crisis, not at those times when suddenly your diagnosis has become terminal. We should be talking about this all the time. Death isn't shameful. Death isn't something we shouldn't talk about, but death can be massively problematic, and we see that sadly because there are people for whom their various symptoms just simply cannot be effectively alleviated. And we've heard some incredibly powerful testimony from people who've contacted us personally and shared something that's very personal to them. And something that will have been very difficult for them both at the time but also to relive it and share those conversations with us. And I think it's absolutely right that we talk about those holistic conversations about death. They're already happening. We're not creating something new here. What we're doing is we're looking for ways we can do that better. And I think that's especially true for those people who are already dying. And the reality is that within this bill we're talking about people who are already dying. We're not creating the option of death for people who are healthy and fit and well. We're talking about people who are already dying. That is an inevitability, and that is defined within those clauses we've already accepted. So for me, we're not changing the social contract. What we're doing is we're allowing an extra option for consideration for those who are already dying. And for me, while there might be some charitable involvement around that service delivery, I certainly wouldn't rule it out. I absolutely believe that this should be part of the health service provision around a good death. And for me, to remove that and to do it in such a, I suppose, a quite blunt way as this new clause seems to do, I don't feel it's necessary. So as much as, yes, there are options around making amendments to the new clause, I actually think we can work really well without it, within what we're trying to achieve here. So I would question why we would build barriers, why we would build bridges, when actually what we need to do is we need to be providing things absolutely at the point of care with the people who've built relationships with those individuals. And I suppose the only other point that I would flag, and this is, I suppose, slightly separate to my sort of impassioned plea, I suppose, that this should absolutely not be a thing that has to be separate with no engagement between the health service and ne'er the twain shall meet. But also that there is a level of concern for me in terms of how Part 6 and Part 7 of the new clause are written, that could inadvertently prohibit someone who works in the health service from supporting their relatives and their loved ones, just by virtue of how some of it's drafted. And I think we should just err on the side of caution. For me, there's no need to look for all of the many changes that I think would be required to bring this to where it would need to get to. I actually think it's just the wrong thing for this bill. Thank you.
Thank you, Mr. Speaker. I'm going to stand up now. Just with regards really to this new clause, we've heard lots of comments, and just from the last honourable mover with regards that it needs to be in our health service, but our hospice isn't in our health service currently. It sits outside. It sits to one side of our health service. It gets funding from the government towards that. So are we just, we seem to be contradicting some of the ways forward that honourable members are standing up and promoting for go with the bill as it is existing, and that really does concern me. As honourable member for Douglas Central stated, this is in principle. We have a right and a duty and a democratic process to discuss anything that comes forward. The honourable mover's done the right thing. She could see that there was concerns, and we should honour that. We're a democratic process, and we should always be considering it. I am also concerned with regards to our health minister. Seems to flip at 1 minute. He wants to be the independent person that's talking about the bill, and it's the right thing, and then a comment will come in about as minister or as Manx Care, etc. I said, and that really does concern me, because it's quite clear Manx Care do not appear to have had any involvement in this bill at this stage, and that is concerning, and that should be concerning to the whole population. I don't think we should be getting comments with regards to our healthcare service without having contribution from them, and whether that is confirmed government policy going forward. It really does concern me. But I feel, because there is so many concerns, so many queries with regard to this, that we should consider this new clause. It's in principle. We should come back with any amendments and debate it further at that point, because there is many good points within it. There's nothing being said about it actually being completely an arm's length service, which honourable members have tried to portray in here today, but there has been no comments with regards to that. So I think we need to consider it's a new clause, it's in principle, democratic process, we should allow that to carry through, and then debate it with any amendments that honourable members who obviously have seen the new clause, but we have a right and a duty to debate with amendments if there are some inaccuracies in this clause in principle. So I do support the honourable mover in bringing this new clause to the bill. We shouldn't be railroading this. We need to be thinking everything through, and that in principle stage is so important. Let's debate it properly next time with amendments. Thank you, Mr. Speaker.
Mr. Warrenberg.
Thank you, Mr. Speaker. I associate myself with the remarks from Mrs. Poole Wilson. There's been a lot of talk here today, not a lot of comments about compassion, and that is why we are here. That is why we're here with people like Simon. It's very difficult. 3 years ago in this house, I stood up and I spoke about Bobby Kennedy saying, we need to tame the savageness of man. We need to make gentle the life in this world. That is what we are trying to do. That is what I'm trying to do. I'm minded to support what Mrs. Lord Brennan has brought forward. I think she's got the makings of something. but I would do so with the caveat that to place all the capacity for providing assisted dying to a charity which is totally outside of normal healthcare currently provided by the NHS Manx Care is to run counter to the principles embedded in Manx Care of peer review and the duty of candour, and to identify lapses of clinical practice. So if she can give me some comfort around those things, I would be very grateful. Thank you.
Call on the mover of the new clause to reply. Ms Lord-Brennan.
Thank you, Mr Speaker, and I thank you for the time and the consideration that honourable members have given to this. I think it's been needed. You know, I think that actually the discussion and the debate around some proposals that have been brought forward show that there's some things that are actually not fully formed already. And kind of, you know, on that point, it sort of ties in with Mr Wannenberg's point, also Ms Farragher's, and also Mrs Barber's. This idea that what has been proposed by me is somehow taking something out of the health service. Well, honourable members, the bill, my point was that the bill isn't providing for it to be in the health service to start with. The bill provides for DHSE to make regulations so that if honourable members actually do wish to have this in the public health service, in the health service and in Manx Care, then you know, I would suggest that it's kind of on members to actually bring that forward and give an opportunity for the House to vote on that. I'm not taking something out of health service. People haven't been upfront about it being in or out. What I've sought to do is provide a model for an option for a quality service that can be overseen and regulated and thought about and considered, because that's not been brought forward on the members. And there is a point about compassion. Now, it's out of compassion, frankly, that somebody bothers to spend this amount of time on something that they don't, you know, that they've got concerns about, because actually they feel a concern and compassion that something like this is steamrolling ahead, and actually it's incredibly important that it's thought through. So we can't always stand here and just talk about compassion. In this House, we also have to think about how things work in practice. So for Mr Wannenberg, I can't give an answer as to how Manx Care would you know, sort of how this would work with Manx Care, because you know that probably actually needs to be thought about elsewhere. You know, but I do agree with his points about there needing to be a proper model. Mrs Paul Wilson talked about, well, what difference would it make for the medical professionals, and not understanding what difference it would make. But the Isle of Man Medical Society has clearly written to us to tell us, you know, the difference that they feel it would make. Well, if we need, basically saying we need to take account of the impact on this if it's in healthcare, and they can feel that actually this amendment provides a model which could stand outside of healthcare, therefore taking away or going some way to address some of the issues as has been articulated in some of the evidence that's been given today. I feel like some basics need to be cleared up. There is a definite difference, and this has been pointed out in the drafting of the amendment, but just for absolute clarity, there is a difference between the provision of assisted dying, the regulation of that, and other care services. And I think that this distinction is really important, because it doesn't present any issue, this amendment, with a discontinuity of treatment at all. There is no reason why existing treatment going on in Manx Care or elsewhere, you know, would be ended by this amendment. Dr. Allenson has said that it would you know, prevent other forms of palliative care. That's absolutely not the case. And when people want to speak about what sort of models may or may not work, well, I don't think that such a model that was delivered in this way, that people would be carrying out, you know, diagnostics and things there. The point would be, it would perhaps be a service that people could be referred into, actually, like the hospice or something like that. So it's not a privatisation model be something that potentially could be referred into. So I don't think there's an interruption of care as people may think, but I do think we need to understand the provision of service versus regulation. I think matters to do, and also advice that doctors may give, that could still all stand. I think that Mr Hooper has put forward a number of things that he would like me to answer in terms of what DHSC might do. So I would put forward, actually, there does need to be thought on this from DHSC, and the time for that is certainly coming. I don't think, in putting forward some proposed amendments, I don't think it's something that I can necessarily specify to the full degree exactly what sort of licensing requirements, exactly, for example, and this appears elsewhere in the bill, what things should be covered in regulations. Essentially, we would absolutely need DHSC to think about those things. And in fact, they would need to think about those things if it becomes clear that assisted dying should be in Manx care, albeit, a licensing arrangement could be something different. I think things like patient records and things like that, and the sharing of that, that's when you start to get into the detail again of something that would need to be figured out along the way. It's an overall proposal of something that could work in a different model, similar to hospice but for assisted dying, to provide a level of separation that would allow for good solid regulation, quality of care, better oversight, and something that creates sufficient distance so that some of the many concerns that have been raised by the Isle of Man Medical Society and Manx Duty of Care, they've put forward thoughts on this, it would mean a lot of those issues go away. And I don't think that there's an issue with having a distinct service, because then actually you can track better how it's working. I do think if members are so set on having in healthcare, they need to come forward and actually amend the bill in that respect, to give us something to vote on. It's not that this amendment is taking something away. It's absolutely not the case that it would be a privatisation model. Mr Callister, I would not be in a position to provide specifics of like how much things would cost, because again, that sort of thing would need to be set out, any sort of requirements and a licensing requirement, something like that. But I would stress again, hospice runs on a model where people get referred to it, but it's kind of got equal access. There is one point that I would recognise that Mr Hooper raised, which is the at subclause 3. I think that the point where it says about provision of assistance under this Act to be treated as the relief of suffering, I think that human suffering, I think that could, that would need perhaps an adjustment, because actually you could tie that point in specifically to link in with the actual overall Act. But the other points, if people think that things need to be tweaked or adjusted, then, I think there needs to be a little bit more clarity around what that is exactly, because there is a difference between providing the regulation and also providing assisted dying. What I'm saying with my clause is that it shouldn't have public funding apply to assisted dying. DHSC would have to carry out regulation anyway, but that regulation is not assisted dying. Mr Morehouse was talking about Manx care as if I was adding Manx care in, so I'm not I'm not doing that, but also I'm not quite sure on what his points were. But I think we need clarity on what sort of model should be provided, and we shouldn't really skirt away from that. So if people are assuming and acting like this is going to happen in Manx care, then perhaps that should be in the face of the bill. And maybe some of the thoughts around all of this have given some of the options that would certainly give comfort to the healthcare professionals and make actually for better regulation. If it was thought that down the line, once you had a distinct service, that something could be moved into, we're comfortable with moving it into all the dynamics of Manx care, then perhaps that is a way forward. But we can't just sneak it in. And I actually genuinely feel if I hadn't have put this clause forward today and people were kind of coming forward with their views and thoughts and saying, well, of course it should stay in healthcare, of course it should be integrated, I feel like it would be sneaking it in, because the bill is not express on what is being required, and there are massive alarm bells being sounded by the medical professionals on which we rely. So if there is to be a service, it needs to be properly thought through exactly around some of the lines that points I've made. But I, of course, as an individual member of the House of Keys, I'm absolutely not going to have all the answers for this. Ultimately, we will end up looking to, DHSC or Manx Care or whoever, to fully inform whatever they're doing. But I would just say, don't be afraid of an alternative model just because it's come as a new idea, and please, treat it in that way. If this isn't supported, there needs to be much greater clarity on what the intention is, because it's too important. This bill is just so thin for what it's dealing with. It does require a lot more thought, and I hope that people can see it is from interest and compassion that I've bothered to do this. Thank you, Mr. Speaker. I beg to move.
I put the question, honourable members, that the new clause be agreed in principle. Those in favour, please say aye.
Aye.
Against, no?
No.
No. Division called. Nine votes for, 15 against. The noes have it. The noes have it. Turn to clause 7. Dr. Allinson.
Thank you, Mr. Speaker. Clause 7 sets out how and by whom assistance in dying may be given. Medicine prescribed for that purpose may not be given for 14 days following the day when the person's declaration took effect. This period for reflection can be reduced to 7 days if the person is not expected to survive for more than a month. In respect of medicine which has been prescribed and delivered to the person requesting an assisted death, an assisted health professional may prepare that medicine for self-administration by the person, prepare a medical device which will enable that person to self-administer the medication, and assist that person to ingest or otherwise self-administer the medication. But the decision to self-administer the medication and the final act of doing so must be taken by the person for whom the medicine has been prescribed. The clause also provides for the option for where the assisting health professional has agreed to administer the medication on behalf of the person for whom it has been prescribed, this may be administered by intravenous injection. Following the taking of the medication, the health professional must remain with the person until the person has died. I'm grateful to Mrs Corlett and Miss Edge for their amendments to remove the provision for a physician administration and for the further clarity provided by the amendments proposed by Mr Hooper and Mr Thomas. Mr Speaker, I beg to move that Clause 7 does stem part of the bill.
Ms Harbour.
Thank you. I beg to second and reserve my remarks.
Mr Hooper, to move your amendments, please.
Thank you very much, Mr Speaker. I apologise, honourable members, there are quite a few amendments. I will try and go through them quite quickly. So, amendment number 25 is a technical amendment inserting a cross-reference to elsewhere in the bill to ensure consistency around the declaration requirements. Amendments 28 and 30 insert the words dispensed and delivered in place of simply delivered. This is to ensure that substances, and I will use the word substances as I intend to support the Honourable Member for Douglas Central's amendments, changing the narrative in the bill, that substances can only be dispensed and then delivered to the doctor or the person in question, that no third parties can act on their behalf. Amendment number 31. It is relatively important. It changes the emphasis ever so slightly around some of the safeguards and requirements in the bill. So it introduces a requirement that in order to be actually provided with these substances that have been approved and have been prescribed, that they have to actually request those substances themselves at the point they want to use them, so they cannot request them months or years in advance. It has to be done at the point they intend to use the substances to reduce the risk of having these substances lying around buildings or homes, perhaps in inappropriate places. It also introduces a further check on the individual's capacity at the time they request these substances and intend to use them, to ensure that the individual's capacity to make these decisions is in force at every point throughout this process. Amendment number 46 is a technical amendment to correct the typographical error. I think it's an incorrect reference to a health practitioner instead of a health professional in the bill. Amendment number 49 is an amendment which, again, I think is quite important. This came out of the committee deliberations in respect of what happens if the procedure following the administration of one of these substances, if the procedure were to fail or not to complete for any reason. So, for example, the individual may have decided not to take the substances, in which case the procedure has failed. The individual may have taken the substances and they may not have had the desired effect. The procedure has failed. The bill, as currently worded, doesn't really provide for that eventuality in respect of the assisting health professional having to hang around until the procedure is complete. This amendment actually inserts a provision that would enable some clarity in respect of how long the individual has to stay, so the health professional can actually make a decision that the procedure has failed and then move on almost to the next stage. Amendment 50 is a requirement to specify in regulations in respect of how drugs would be prescribed, the storage, disposal, etc. in respect of medications. Currently the bill leaves this as an optional provision, but my view is this should be a mandatory provision. Amendment number 53 is a technical amendment to ensure consistency, again, between various parts of regulations. Amendment number 54 is another technical amendment correcting a typographical error referring an assist health professional rather than assisting health practitioner. And then number 55 is, again, an important amendment as it introduces the requirements for dispensing and delivering of drugs rather than simply dispensing. So it adds a slightly enhanced amount of security and safeguards around those amendments. I think I've moved all of them, Mr. Speaker. I don't think I've missed any. So you're ticking them off as I was going along. That's great. Thank you very much, Mr. Speaker. I beg to move all of those amendments.
Thank you very much, Mr. Hooper. Now, honourable members, it is 5:30. Dr. Hayward.
Second the amendment.
No, I'm afraid it's 5:30. We will pick up that at the next sitting. Point of order, Mr. Thomas.
Point of order. I just thought you might allow somebody just to thank Stapleton.
Well, I will, of course, do that, yes, as I did last week. Yes, Dr. Giles.
Mr. Speaker, could I propose that we continue until we've moved the various amendments and then suspend the session after these amendments have been moved in their entirety?
You're seeking to make sure that all the amendments are moved and seconded before.
Yes, please.
Second, Mrs. Kane.
Need a second.
I put the question then that the sitting continue to ensure that all of the amendments are moved and seconded. Those in favour, please say aye.
Aye.
Against, no.
No.
Divide. Just to advise honourable members, a simple majority is required for this decision. 14 votes for, 10 against. The ayes have it. The ayes have it. Mr. Hooper, having moved his amendments, I call on Mrs. Kane.
Thank you, Mr. Speaker. I beg to second. I think these are small, subtle, but important improvements. Thank you.
I call on Mr. Thomas.
Thank you, Mr. Speaker. And so personally, before I move my amendments, I'd just like to thank Stapleton for sitting here all day, for being prepared to speak, to give evidence and to answer questions in my written statement. I really do hope that you can come back when we reconsider this clause at a later stage. I don't think that Dr. Randall is able to do that, but it was so great to hear from the speakers that were arranged by other people that I do think it would be great to it's sad that we've lost that opportunity, and I hope we can recreate that opportunity. In terms of moving the amendments, Amendment 50, which is also in my name as well as in Mr. Hooper's name, is a very important amendment. It basically talks about requiring DHSC to consult about the principles and the draft regulations according to the consultation and engagement principles of government, and then to bring them to Tynwald for approval we need the department to make regulations which specify the medicines or the substances, I notice Minister Hooper's now calling them, which may be prescribed under this section, the form and manner in which such prescriptions are to be issued, and the manner and the conditions under which such substances are to be dispensed, stored, transported, used and destroyed. And we'll need an amendment to change that to substances from medicines, because obviously we've got into issues. Because that's the second part of my amendment. I've got a whole bunch of amendments which basically change in the singular or in the plural medicine to approved substance throughout clause 7 and indeed in the schedule as well, for which you want me to move that at the same time. Essentially, we looked. I looked at as much legislation as I could, talked to as many people as I could, prepared questions for witnesses to help us understand these processes, and it does seem that substance is the important point in this. We need to get to develop a new regime for the regimen of this process. We're in uncharted territory in this area, so we need all the guidance and all the advice we can get, because this is a very difficult task to solve, and we're doing it ahead of others. So therefore, which substances would be used, how would they be licensed, how would their use be controlled, and I do hope that people don't see this as being this is a poison, this is a noxious substance, this is something to do which we should be borrowing from the animal welfare regulation. This is a serious business. We're looking now to make this practical if this gets enacted and then brought into force, and so therefore we need we need to change other pieces of legislation to fit in or to align with this legislation around the regimen of assisted dying if we choose to do so. This is practical. Beg to move.
Mr. Warrenberg.
Thank you, Mr. Speaker. I beg to second.
Thank you. Next one is Mrs. Corlett, please.
Thank you, Mr. Speaker. I have in previous debate stated my intention to bring forward an amendment to the bill that would allow a person with a terminal illness to end their own life, but would not allow another person to do that for them. Amendment 33 would omit subsection 5 from clause 7 of the bill. The intention of the amendment is to only allow self-administration of medicine for the purpose of ending your own life. Amendment 36 simply would take out the words which is to be self-administered if Amendment 33 were to be supported. Amendment 42 is self-explanatory. This amendment simply does not allow an assisting health professional to administer a medicine to another person with the intention of causing that person's death. Amendment 44 omits section 7 if Amendment 33 is supported. This subsection would not be required. Amendment 48, again, if Amendment 33 is supported, this amendment substitutes the words in subsection 8 to remove reference to administration of the prescribed medicine by an assisting health professional. Amendment 59 would simply remove the words otherwise administered. Thank you, Mr. President. I beg to Mr. Speaker, sorry.
Ms. Edge.
Obviously, I'm happy to second these amendments today. I think it's really important to keep the actual process of the administration of the Act to the individual. It's their choice, and they've chosen to do that, so I think that's really important. Thank you.
I call on Mr. Smith to request leave of the House to move an amendment to amendment number 48.
Thank you, Mr. Speaker. I duly request the leave of the House if I can make a minor amendment to amendment number 48. Thank you.
Mr. Smith, is the House content? I'll put the question whether the House is content to give Mr. Smith leave to move his amendment to the amendment 48. Those in favour, please say aye.
Aye.
Against, no. The ayes have it. The ayes have it. Mr. Smith, I call on you to move your amendment.
Thank you, Mr. Speaker, and also to the House for allowing me to table this amendment to the amendment. I acknowledge what the honourable members, Mrs. Corlett and Miss Edge, are seeking to achieve within their tabled amendment. However, I believe that there remain fundamental points of concern regarding both the person wishing to proceed with self-administering the substance and the assisting health professional, which it states must remain with the person until the person has A, self-administered the medicine and died, or B, decided not to self-administer the medicine. It is crucial at this stage to acknowledge the serious implications can arise when toxic substances are ingested. The essence of this bill is to give ultimate protection to the individual who is self-administering a substance to unnaturally end their life, that the process leads to a dignified death. Within the current list of assisting health professionals referred to in subsection 4 are A, an assisting health professional, B, an attending doctor, C, an independent doctor, D, a registered nurse, E, a registered pharmacist, and F, a registered psychiatrist. I remain to be convinced that anyone other than an attending doctor or other qualified medical practitioner could appropriately respond to someone who was experiencing complications following the ingestion of a toxic substance. I have canvassed the opinion of 3 long-standing, highly respected island-based pharmacists, including one esteemed former member of this House and the other place. They are all unequivocal in their opinion that as pharmacists they do not have the necessary training or requisite competencies to individually deal with someone who could suffer severe complications following the ingestion of a toxic substance. The rationale could similarly be linked to other persons referred to as assisting health professionals. Mr. Speaker, with safety being paramount and a dignified death being the ultimate outcome, I therefore wish to ensure that a doctor or other registered medical practitioner must be in attendance and remain with the person until the time of their death. I beg to move. Thank you.
Mr. Thomas, your point of order?
A procedural motion, or just a question really for you?
Well, that's a point of order.
I know there are people who've actually got quite long speeches, and we're wanting to spare the House from their quite long speeches, who would second this motion. I think it's perfectly reasonable to have this amendment to an amendment seconded at the next sitting, so that the people who've got long speeches who are hesitating to use them at this time of hour can actually wait. So it seems to me it's entirely in your hands. You could allow for this amendment to be seconded at the beginning of the next sitting.
Well, the resolution of the House is that all proposals and amendments must be on the floor before I adjourn the House, so I therefore seek a seconder to Mr. Smith's excuse me, Mr. Smith's amendment to. If no, well, thank you, Mr. Cannon.
Solves the problem.
In which case, then, all of the amendments have been proposed and seconded in accordance with the resolution of the House. We will conclude the consideration of the assisted dying bill at that point. As I previously indicated, can I, on behalf of the whole House, thank our guests for their time and their evidence today. It's been much appreciated on this important subject. Yeah. And with that, the House stands adjourned until our next sitting, which is on Tuesday, the 21st of May, as part of Tynwald Court. Thank you, honourable members.
Thank you for making it to the end of the Little Manx Radio newscast. You are obviously someone with exquisite taste. May I politely suggest you might want to subscribe to this and a wide range of Manx Radio podcasts at your favourite podcast provider, so our best bits will magically appear on your smartphone. Thank you.